Can start.
YouTube live idella?
Yes, sir.
Okay. Good evening, everyone, and welcome to the fifth monthly ISA Karnataka webinar. Today we have two esteemed speakers, Professor Dr. Ravi. Professor Dr. Ravi from HOD of Anesthesia at JJ Medical College, Davangere, and Dr. Nazir Ahmed, Professor at Alamin Medical College, Vijaypura. And we have Dr. Kodan Ram, Professor and Director of Anesthesia at ESI Medical College as moderator, and Dr. Professor Avati also as moderator for this session. Without wasting much time, I welcome you all. Eli sir.
Go ahead. Yeah, he's unmute.
Yeah. I welcome all the speakers, the moderators, esteemed national, regional, and state office bearers, and all the participants, including postgraduates, for this session. With this brief introduction, I invite our President, Dr. Vijayanand sir, to please welcome and give his opening remarks. Over to you, sir.
Thank you, Sri Ganesh, Secretary, Karnataka ISA, Vice President, Dr. Shivkumar Kambar, all the EC members of the Karnataka chapter of Indian Society of Anesthesia, Dr. Bal Bhaskar, National Immediate Past President and Academic Chairman of the ISA National, Dr. Gurudat sir, Professor Head of the Department from JSS Medical College, and Academic Advisor to the KISA, and all the dignitaries, Dr. Venkatagiri, President-elect of ISA National, Dr. V.B. Gowda, President of the ISA Bangalore chapter, and senior anesthesiologists, postgraduates, and I also welcome the two eminent teachers of our time, Dr. Kodan Ram, former professor and director of ESI Postgraduate Institute, Rajajinagar, and Dr. Madhav Avati, a very well-known teacher in the North Karnataka. I welcome both of them as a moderator. I welcome all the postgraduate. This is the fifth academic activity of the Indian Society of Anesthesia monthly, which will be done on every month on the second Thursday. And every meeting has been improving, and we are getting a lot of acclaims, criticisms, and a lot of related advisors, and we have improved on this. Thanks to the two eminent people, Dr. Bal Bhaskar and Dr. Gurudat sir, for their continuous effort in updating and modifying this activity, which has become a role model, and many of the states are following this footstep there. I welcome once again everybody, all the dignitaries, senior anesthesiologists, teachers, and postgraduate, to make use of this academic activities, which is becoming very popular in Karnataka and outside. I once again welcome all the people. Dr. Ganesh, please proceed further, please.
Thank you, sir. Now I request our academic chair, Bal Bhaskar sir, to say a few words, and then we'll move to the moderators to take this program forward. Bal Bhaskar sir.
Ganesh, can you hear me?
Yes, sir. Ravi sir, I can hear you.
Can you see the PPT there?
Yes, sir. Yes, sir. We can see, sir.
It's there, right? Okay.
Yes, sir. No problem, sir. It is perfect, sir.
Yeah. Thank you very much, Dr. Sri Ganesh. Dr. Vijayanand, President of ISA Karnataka State Branch, Dr. Sri Ganesh, Secretary, then Dr. Shivkumar, Vice President, and Dr. Gurudat sir, the member of the Scientific Committee of ISA Karnataka, and all the members of ISA Karnataka, and especially the moderators for the day, Dr. Kodan Ram sir and Dr. Avati, two senior most faculty of ISA in Karnataka. I thank them that they have agreed to participate as moderators and share their wisdom and knowledge along with the presenters of the day. And of course, among the presenters, we have got Dr. Ravi. He is a professor and HOD at JJMC Davangere. And
I am here in the webinar. Don't call me.
So he is an authority in cardiac anesthesia and is very good in critical care. And I am also happy that he has accepted to participate and he is raring to go now. And then we have got Dr. Nazir Ahmed. He is a private practitioner in pain, along with being an active academician. He is a professor in Al-Amin Medical College in Bijapur. So he is going to share some knowledge which is very basic for the private practitioners so that they become interested in pain medicine. So I welcome all the members from within Karnataka, outside Karnataka, and I see a lot of our own colleagues from ISA National, including Dr. Venkatagiri, Dr. Kameshwar Rao, and other senior members. So welcome everybody once again. Over to Dr. Sri Ganesh, please.
Thank you, sir. As is our format since the beginning of this monthly webinar, we will be having some quiz questions for the audience. Dr. Ravi talk will be predominantly for the postgraduates, and following his presentation, he'll have three quiz questions. Please type the question number as Q1 and then answer A, B, C, D, or 1, 2, 3, 4, so that we can identify the first correct answer correctly. Similarly, Dr. Nazir's presentation is predominantly directed at practitioners, and that is open for practitioners to answer. Again, we'll have three quiz questions, and the fastest correct answer will be given certificate of appreciation from ISA Karnataka. With these words and welcoming all participants of this program, I request Kodanram sir to kindly take over and welcome our first presenter, Professor Ravi. Over to you, sir. Kodanram sir. Dr. Kodanram is the Director Professor and ex-Dean of ESI Medical College, Bangalore. And we have Dr. Mahadev Avati, again, Professor of Anesthesiology at MIMS, Vikarabad. Sir, Kodanram sir, please unmute yourself.
Hello.
Yeah, please go ahead, sir. Yes, sir.
Thank you, Dr. Sri Ganesh, for the kind introduction. I invite all the people from Karnataka and outside to attend this program, which is a wonderful educational program, and is looked forward by all the postgraduates and practitioners every month. It's a great step forward in the academic work being done by ISA. Now, the first talk is about the causes, recognition, and management of intraoperative arrhythmias by Dr. Ravi. Ravi is the head of the Department of Anesthesia and Professor and HOD in Davangere Medical College. I request him to take over and start speaking regarding the topic. Over to Ravi, please.
Ravi sir, please share your screen. Meanwhile, I request Gurudas sir to please say a few words, and then we'll till Ravi sir shares his screen. Gurudas sir, unmute yourself and then.
Hello, can you see the slide?
No, sir, we can see you, Ravi sir. Please share the screen.
Okay.
Gurudas sir, you can please go ahead till Ravi sir shares his screen.
Yeah, thank you, Dr. Sri Ganesh, and my greetings to everybody who is who has logged in, and for both the dignitaries and also the chairpersons and the speakers, and also all the postgraduates who have participated in this. So this is, as already you have told, that this is the fifth session of our regular monthly teaching programs. I think it has become quite popular, and because we are getting very good speakers to speak on. So let us hope this also will be a very good session. Both Dr. Ravi, I know him very well, and he is the professor and head of the Department of Anesthesia in Davangere. And Dr. Nazir, he was my student in Ballari. So he is also very enthusiastic in participating for this particular session of our ISA Karnataka. So over to Dr. Ravi for his lecture.
Can you see Ganesh slide?
Yes, sir. Please make it full screen, sir, and then you can start.
Yeah. Okay.
From the beginning on the left corner, sir.
Sri Ganesh, can I interrupt a bit here?
Yeah, please, sir. Go ahead, sir.
Sir,
It's okay
as
for you?
PowerPoint shows as use timings and other things, the PowerPoint settings, previous
Okay,
timings might be active. Maybe he has to remove that part. When we have that, use the rehearsal timings, there is some rehearsal timing which is active.
Ravi sir,
Yeah.
ನಿಮ್ದು ರಿಹರ್ಸಲ್ ಟೈಮಿಂಗ್ ಏನಾದ್ರು ಆಕ್ಟಿವ್ ಮಾಡಿದ್ರಾ?
ಇಲ್ಲ ಮಾಡಿದ್ದೀನಿ. But can you see the screen now?
Yeah, we can see the screen. You can disable that. Otherwise, it we might have some problems.
Where is that? I don't know.
View. Please go to view, sir. Once. Slideshow. Slideshow on the previous screen only. Just the previous screen, sir.
ನಿಮ್ಮ ಲ್ಯಾಪ್ಟಾಪ್ ಅಲ್ಲಿ ಸರ್?
ಲ್ಯಾಪ್ಟಾಪ್ ಅಲ್ಲಿ PowerPoint setting ಅಲ್ಲಿ
1 minute.
Slide
ಇದು ಸ್ಲೈಡ್ ಶೋ ಆಫ್ ಮಾಡಿ ಸರ್ ಫಸ್ಟ್.
ಸ್ಲೈಡ್ ಶೋ ತೆಗೆದ್ಬಿಡಿ ಸರ್.
ಫಸ್ಟ್ ತೆಗೆದ್ಬಿಡಿ.
ಸ್ಟಾಪ್ ಸ್ಲೈಡ್ ಶೋ ಬರ್ತದೆ ಟಾಪ್ ಅಲ್ಲಿ.
ಎಸ್ಕೇಪ್.
Right now, what should I do?
ಎಸ್ಕೇಪ್ ಪ್ರೆಸ್ ಮಾಡಿ. ಸರ್ ಈಗ ಮಾಡ್ತೇನೆ ನೋಡಿ ಸರ್, ಮೇಲೆ ಯೂಸ್ ಟೈಮಿಂಗ್ಸ್ ಅಂತ ಇದೆಯಲ್ಲ, ಅದನ್ನ ತೆಗೆದ್ಬಿಡಿ ಸರ್. ಸೆಂಟರ್ಗೆ ಸ್ಲೈಡ್
ಶೋ ರೆಡ್ ಹೆಡಿಂಗ್ ಇದೆ, ಅದರಲ್ಲಿ ಸೆಕೆಂಡ್ ಒನ್ ಸರ್, ಯೂಸ್ ಟೈಮಿಂಗ್ಸ್ ಅಂತ ಇದೆ ನೋಡಿ.
Use timings, right?
Disable ಮಾಡಿ. ತೆಗೆದ್ಬಿಡಿ. Yeah, fine, perfect.
Yes, sir.
We go ahead.
Yeah, please, from the beginning and you go ahead, sir.
Now correct, sir.
Okay, right?
Yes, sir, please, sir.
Right. Thank you very much. Thank you all for giving me an opportunity to talk here in front of you. All my colleagues, friends, my seniors, my teachers. Kodanram sir.
Hello, Ravi.
Thank you, Balavaskar. Thank you, Ganesh. Thank you, Vijayanand. Thank you very much. So today's talk on perioperative arrhythmias, and I also color some of the things which have been apart from perioperative. Also, I should say 1 or 2 slides, because to complete the show of the arrhythmias, I should say something also. So I can go ahead with this. Thank you very much. So these arrhythmias are a group of disorders. Were characterized by characterized by irregular rhythm instead of normal sinus rhythm. That may be either too fast or too slow. These are all irregular rhythm instead of normal sinus rhythm. It can be neither too fast or slow. We can classify these arrhythmias into 3 types: heart and irregularities, site of origin, mechanism of formation. So this includes the classification also does come under, say, some of the causes also. So this classification, why I justified is, it tells you the causes also sometimes, right? So these are the causes, and these are all the classification. Heart and regularities. The arrhythmias can be broadly classified into bradyarrhythmias and tachyarrhythmias. And the broad heading of the bradyarrhythmias, the simple bradycardia, then a heart block. It also concludes 6 sinus syndrome. And tachyarrhythmias, we can describe it narrow complex and a wide complex. Narrow complex, thus to say, is less than 120 milliseconds. The wide complex is more than 130 to 120 milliseconds of the QRS complex. So narrow complex includes sinus tachycardia, supraventricular tachycardia, atrial fibrillation, atrial flutter. And the main 2 important QRS wide complex tachycardias are ventricular tachycardia and ventricular fibrillation. It also can be classified on the site of origin. It can be above the ventricle, that is supraventricular arrhythmias, and at the site of the ventricular, that is below the junction of the AV node, it is ventricular arrhythmias, sinus tachycardia, atrial fibrillation or flutter, atrial tachycardia, and PAC. It comes under the supraventricular tachycardia. And ventricular tachycardia is again ventricular tachycardia, and then premature ventricular contractions and ventricular fibrillation. Another way of classification is important, where we can justify our causes also in that. That is abnormal impulse conduction and abnormal impulse formation. 2 types are there. In that abnormal impulse conduction, brady or tachy may be there. And bradycardia, naturally, it is conduction block and 6 sinus syndrome. Tachycardia is re-entry phenomenon. In abnormal impulse formation, bradycardia may be due to the reduced automaticity, and tachycardia may be due to triggered activity, enhanced automaticity, and abnormal automaticity. So enhanced automaticity, it is mainly due to pacemakers, SA node, AV node, or Purkinje fibers. So abnormal automaticity is mainly due to ventricular myocytes. So like that, the mechanism can also say something about the causes. So now go to the pathophysiology of this. The pathophysiology of arrhythmia may arise from abnormalities of the impulse generation or conduction, one of these. So abnormal impulse generation include enhanced normal automaticity. You know, heart consists of pacemakers like SA node, AV node, Purkinje fibers. So these pacemakers have an inherent property to generate impulses themselves, and these control the heart rate. So in healthy patients, SA node generates around 60 to 100 beats per minute, relatively high discharge than other pacemakers, and the AV node around 40 to 60 beats per minute, and Purkinje fibers, they relate when the other stops, these pacemakers start working around 20 to 40 beats per minute. Coming to enhanced automaticity of the pacemaker, it results due to increased rate of cardiac action potential, so which disturbs regular rhythm and produces arrhythmias. So cardiac potentials will be increased and disturbs the regular rhythm, producing the arrhythmias. Abnormal automaticity is the spontaneous impulse generated in the fibers. The spontaneous impulse, once generates this impulse in the fibers, they act partially deprioritized by pathological process. So that is about abnormal automaticity. And triggered activity mainly due to oscillation in the membrane potential. So these are the main three causes that could produce the arrhythmias. So in abnormal impulse conduction, re-entry is the basic mechanism. Re-entry accounts for the majority of the tachyarrhythmias. Here, the electrical activation of the wave retrograde into the myocardial region, which is initially refracted to the antegrade conduction. So originally it is refracted to antegrade conduction. So activation occurs in the retrograde into the myocardial region. So retrograde myocardial region produces arrhythmias. So many causes, many factors, contributing factors are there to produce arrhythmias. One is hypovolemia, hypoxia, electrolyte imbalances, hypothermia. When the septal temperature goes around minus 18 degrees centigrade, there will be precipitation of the arrhythmias, hypoglycemia, acidosis, mechanical irritation. Any mechanical irritation does produce cardiac ischemia, coronary artery disease, myocardial infarction can produce arrhythmias, lighter planes of anesthesia, and drugs, toxins, tamponade, cardiac tamponade, any tamponade can produce arrhythmias. Tension pneumothorax and hypertension, bradycardia can produce arrhythmias. Trauma, thrombosis, and surgical cause, traction, oculocardiac traction, cardiac compressions, cardiac manipulations, then dilatations. So these can produce, these are all some of the factors which produce these are all arrhythmia. Factors associated with intraoperative arrhythmias. We coming to the what are the factors that related to the intraoperative. There are three factors which does affect in intraoperative. One is patient-specific factors, anesthesia-related causes, and surgical-related causes. The patient-specific factors any pre-existing cardiac disease, could be coronary artery disease, or myocardial ischemia, myocardial infarction, or valvular heart disease produces the perioperative arrhythmias. CNS disorders like subarachnoid hemorrhage can produce an ECG change and arrhythmias. Old age can produce post-op atrial fibrillation, very common in old age. And degenerative diseases like Lehners and Langer's diseases, they do produce the arrhythmias. Anesthesia-related causes like halothane, enflurane, general anesthetics mainly, and regional like central neural blockade, arrhythmias can produce due to parasympathetic predominance here. Electrolyte imbalance like potassium. Potassium is the one hypokalemia and hyperkalemia imbalances. It does produce the potassium. And magnesium that has been used excessively in ascites D points that can also produce arrhythmias. Central venous CV cannula when it's been introducing into the SVC can touch the SA node, can produce irritation into the RA, right atrium, and then produce the arrhythmias. Then the hypoxia. These are some of the causes. Which produces the factors and related to anesthesia-related causes, right? Then surgery-related causes. The cardiac surgery, various steps in cardiac manipulation of the heart, and then the SVC cannulations, IVC cannulations, and then the bursting. When you take a bursting into the aorta, that also causes the surgery-related arrhythmias. Non-cardiac surgical vagal stimulation, like an oculocardiac reflex and anal dilatation, so many causes that produce vaginal dilatation, which vagomimetic actions, so that can produce arrhythmia. So these are all some of the factors, these are some of the causes intraoperatively that produce the arrhythmia. Now, when we discuss all these arrhythmias, we'll have to specifically discuss some of the arrhythmias that produce intraoperatively, and some of the others also. We can go ahead with this. The specific arrhythmias, broadly we said, is tachyarrhythmias. Tachyarrhythmias is the cardiac disorders characterized by abnormal cardiac rhythm with ventricular rate exceeding 100 beats per minute. They call tachyarrhythmias. A ventricular rate exceeding around 100 beats per minute. It's not only ventricular beats, even ventricular slow rate is also there. If the atrial reach exceeding 100 beats per minute, that also can produce tachyarrhythmias. Most of the time, these are all symptomatic and needs to be attention, and these needs to be attention of the physicians. Supraventricular tachycardia. We come to another important arrhythmia, that is supraventricular tachycardia. This is an arrhythmia. It is called as referred as supraventricular arrhythmia because they require atrial or atrioventricular nodal tissue for the initiation and maintenance of the and production of the supraventricular tachycardia. They require either an atrial tissue or AV nodal tissue to produce this. So this can be occasionally sudden onset and sudden termination is there. That is called paroxysmal supraventricular tachycardia. So they may be irregular or regular, or maybe rapid rhythm, or they may be a narrow complex, or they may be a few wide complex. So there are so many instances we can quote them: regular, irregular, narrow, or wide, where the supraventricular and the ventricular. So we'll discuss some of them in future. So supraventricular tachycardias, they're wide complex tachycardia. Wide complex tachycardia, supraventricular tachycardias are there. What are they? SVT with aberrance, that is including the accessory pathway. SVT with aberrance, with a block. The block, or maybe a right or a left branch block with an SVT, can produce the wide complex tachycardia. The narrow complex tachycardia are irregular and regular. In the irregular, the multifocal atrial tachycardia and atrial flutter, atrial fibrillation are the irregular arrhythmias in the narrow complex. In the narrow complex tachyarrhythmias, regular are atrial fibrillation, atrial tachycardia, atrial flutter, and then atrioventricular reentrant tachycardia, atrioventricular nodal reentrant tachycardia, and sinus tachycardia. These are all regular. I'm sorry, it's not atrial fibrillation. Atrial fibrillation comes under irregular rhythm. Okay, so main is atrial flutter. Even it comes either in both irregular or regular. So AVRT, AVNRT are the main schemes that produce in the regular rhythms. So we should be talking wide complex SVT with aberrance. That is, we speak on aberrance. It could be a bundle branch block, a right and left branch block. It could be the wide QRS complex as an SVT. So pathophysiology SVT is re-entry induced by a premature atrial or ventricular ectopic beat. So one of these beats is a premature atrial or ventricular ectopic beat. So the precipitating factors of these SVTs are hyperthyroidism, caffeine, alcohol, drugs, and there are many. In fact, there are many are there. There are many are there. Okay, I'll come back. This chart is not there. So SVT may be due to some lung diseases also and heart diseases. So it's like heart disease, like mitral valve prolapse, rheumatic heart disease, pericarditis. There are many are there. So there are subtypes are there in SVT. What are those? They are atrial tachycardia. Atrial tachycardia either could be sinus or the focal atrial tachycardia or junctional, and atrioventricular nodal re-entry tachycardia, atrioventricular re-entry tachycardia. These are all subtypes of supraventricular tachycardia. So sinus tachycardia is a rapid, regular heartbeat with a rate of around more than 100 beats per minute. Rate of around more than 100 beats per minute with a narrow QRS complex. So this is the sinus tachycardia, where you can see it's more than probably around 100 beats per minute, and exactly not calculated, but it's more than that. So this is the sinus tachycardia. And AV re-entry tachycardia, it is the second most common of SVT, PSVT. This is when there is an accessory pathway, apart from a standard pathway of conduction between atria and ventricle, there is an accessory pathway. This accessory pathway may conduct impulses in an antegrade form or in a retrograde fashion, or both. So this produces tachycardia. So Wolff-Parkinsonism-White syndrome is referred in the AVRT, where there is a delta wave. It can be either retrograde or in the antigrade, it can produce tachycardia. So this is very commonest conditions we come across sometimes, WPW syndrome. So this uh, tachycardia can be again subdivided into, can be orthodromic AVRT or antidromic AVRT. Most common type is the AVRT conduction is orthodromic AVRT. So impulses proceed in an antigrade fashion initially within the AV node, and then it comes in retrograde fashion to join to the sinus node in an accessory pathway. So coming back in an accessory pathway. So here, the difference is here, it produces a narrow complex tachycardia. So in antidromic AVRT, the impulses travel in the antigrade form within the accessory pathway, and then pre-excitation of the ventricle producing the broad complex wide QRS tachycardia. So this, as you can see, is the orthodromic narrow tachycardia, which comes in the nasal node, which comes to the ventricle, pre-excitation of the ventricle, then goes back in the accessory pathway. So this presents with the narrow complex tachycardia. And then wide complex tachycardia, where it comes in a retrograde fashion to stimulate in the accessory pathway and then pre-excitate at the ventricle. So this produces antidromic wide tachycardia. This is one of the reasons, SVT with aberrancy, SVT with wide complex. There are some other focal atrial tachycardia. It can be sustained or non-sustained or paroxysmal SVT, can present with a normal AV conduction or without a block. It can be arising from the RA or it can be arising from the LA. It shows the different configuration of the ECGs. This is the focal atrial tachycardia. It can be associated with 1:1 or 2:1 block, where two atrial impulses to one ventricle. So it can be 2:1 or 1:1. So how do you manage this supraventricular tachycardia? They respond to adenosine. Adenosine response, it depends on the mechanism. And then vagal maneuvers. So vagal maneuvers can be done. Cardioversion will be effective if automaticity is underlying mechanism. You can give a cardioversion. It will be effective depending on the mechanism. So the main aim of treatment, main drugs of the treatment are beta blockers and calcium channel blockers. So improve the tolerance of the arrhythmias. So you also note the precipitating causes for this. Beta blockers, calcium channel blockers, antiarrhythmic drugs, and these are all some of the main drugs that has to be used in the SVT. So catheter ablation, if refractory to above drugs, you can use it. Coming to atrial flutter. Atrial flutter is atrial contraction rate around 240 to 400 beats per minute. It usually associates with some degree of AV block. So the ECG is showing the flutter waves in lead 2, lead 3, and AVF. The negative flutter waves in these leads, and the sawtooth F waves are there, flutter waves are there, that you can see it. Sawtooth and P waves are always merging towards the QRS complex. So there are more P waves than the QRS complex. So these one thing you should note, the RR interval sometimes they don't vary. It varies in atrial fibrillation, that I'll show you in the next slides. So treatment is general treatment, control the rate, ventricular rate, restoration of the sinus rhythm, and prevention of the recurrence, and prevention of the thromboembolic complications, and minimize the complications from the therapy. So this is flutter, atrial flutter. In acute condition of the atrial flutter, cardioversion is mandatory. So if the duration of the atrial flutter is less than 48 hours, cardioversion must be done initially, follows anticoagulation. Anticoagulation should be associated with the cardioversion because prevent the thromboembolic phenomena. Then beta blockers, calcium channel blockers, they are all there to ventricular rate control, and then the rhythm control is followed by any antiarrhythmic like amiodarone, right? So atrial fibrillation, it's irregular rapid atrial activation. There is a loss of proper atrial contraction and irregular ventricle rate depending on the AV nodal conduction. On ECG, there may be about more than 300 beats per minute. You cannot find P wave, no distinct P waves, and a PP intervals is also not regular, and RR interval, mainly you calculate an RR interval. RR interval is irregular. Where you see any ECG, the atrial fibrillation, you should go with the RR interval. That is 1 hour to another hour, just irregular. So that you can notice 2-hour interval, RR interval. So you can see sometimes each other RR interval close to come together. Sometimes it is also called as group beating. So there is no P wave, exact P wave, and it's undulated P waves. You cannot find it. So PP wave is also not, not standard, and the RR interval is irregular. This is called irregularly irregular. So immediate treatment is cardioversion around 100 to 200 joules. You should keep an increment doses. Prevent systemic embolization. Rate control. Ventricular rate should be around 100 per minute. That is by beta blockers, calcium channel blockers like verapamil and diltiazem. Digoxin can be considered if there is coexisting heart failure or in a patient who is intolerant to these drugs. Digoxin can be, considered. So rhythm control, any antiarrhythmic drugs could be amiodarone fine. So these things can be done with an atrial fibrillation. Coming to ventricular arrhythmias, we'll go to the next. The system of arrhythmias are ventricular arrhythmias. These are mainly premature ventricular arrhythmias. A single ventricular beat that falls earlier to the next anticipated supraventricular beat. This is called the ventricular ectopics or ventricular beats, premature ventricular beats. So these can be unifocal or multifocal. With respect to the single focus, I can be multifocal. So unifocal is most of the time is monomorphic QR complex. Multifocal, there are polymorphic QR complex. So this is all the unifocal QRS complex. You can see the similarity. It arises from the one part of the ventricle where it can be producing a unifocal. The multifocal, different parts of the ventricle give rise to ectopics. So that is multifocal. So ventricle, the next is ventricular tachycardia. When 3 or more consecutive ventricular contraction occurs at the rate of more than 100 beats per minute, we call it the VT. So when the VT is slow, when the slower heart rate is called idioventricular rhythm. So idioventricular rhythm when it's slow. Any of these AV dissociation, fusion beats, capture beats can lead on to VT, can give rise to VT. These are all alternative to VT. So it's very important. AV dissociation, fusion beats, and capture beats all terminates in the VT sometimes, right? So you should be very careful. These beats should be recognized in ECG, right? So even whenever there is RS complex is absent, the RS ratio is more than 100 milliseconds, you consider it as VT. So when VT terminates spontaneously within 30 seconds, that is called non-sustained VT. When VT lasts longer than the 30 seconds, but it needs to be an intervention, it is termed as sustained VT. It needs a medical emergency and the intervention immediate. So this is how the VT looks. There are no RS. You look at the RS and you look at the QS. QS is more than 100 milliseconds. So this is the ventricular tachycardia. Another is ventricular fibrillation. The most important ventricular fibrillation. It's a disorganized contraction, the hemodynamic collapse, and a sudden death. There are fine ventricular fibrillation and the coarse ventricular fibrillation. So this fine ventricular fibrillation, not defibrillator, you can convert into coarse by giving on 0.1 ml of adrenaline. So if it becomes a coarse, you can defibrillate these things. So it's in a medical emergency. You hardly have a blood pressure. So it's almost considered an asystole. You should be intervening as early as possible when ventricular fibrillation are there. So first aim is to defibrillate, go on increasing the defibrillation from starting from 200 joules to 300 joules, somewhere around, right? So this is defibrillation. Then along with that, you should use antiarrhythmic drugs, usually include beta blockers, calcium channel blockers, sodium channel, potassium. These are all amiodarone, whatever it is. These can be used regularly. So other than that, you can use an ICD, implantable cardioverter defibrillator. So catheter ablation, one, then surgical ablation. These are all, one, this is what is implantable cardioverter defibrillator. In case of ICD, is recommended only if there is life expectations more than 1 year. If you can expect the life more than 1 year, you can put this intracardiac defibrillators. Now coming to another set of is bradycardia, bradyarrhythmias. Bradyarrhythmias may result either because of the failure of impulse elicitation or impulse conduction. This bradycardia we consider when it's less than 60 beats per minute. So causes are many: hypos, total spinal hypothermia, suxamethonium, morphine, many are there. So one of that is apart from the sixth sinus syndrome, the nocular pressure, neostick, many are there. So we have to give atropine 0.6 milligram, and the vagolytic dose is around 1.8 milligram. If it is not responding, then you can go for isoprelin. If that is also not responding, you can go for a pacing. So with this, you can add on another dopamine, dopamine, adrenaline, noradrenaline, whatever it is to combat the hypertension associated condition, right? So that is bradycardia. So coming to small words of a sixth sinus syndrome, it is dysfunction of the node, dysfunction of the SA node, either due to abnormalities of impulse generation or impulse conduction. ECG showing severe bradycardia, sinus pass arrest or exit block can be there. It is also called bradycardia and tachycardia syndrome. This is very important. Bradycardia and tachycardia syndrome. The treatment wise, if you try to treat bradycardia, by atropine, tachyarrhythmias will be there. If you try to treat tachyarrhythmias, bradycardia. So this is called bradycardia. It's a tricky of treatment. But anyway, we'll have to, this is a pass, and the treatment we'll have to treat according to hemodynamical. Hemodynamically, it's unstable, go with an atropine. The transcutaneous spacing is fine. And along with that, you will have to support inotropes and transvenous have to pace. And if it is stable, consider it, and immunologically stable, evaluate and reversible causes can be done. This is about the sixth sinus syndrome. The long-term treatment, permanent pacing is standard, and anticoagulation is a must, prone to develop atrial fibrillation and thromboembolic complications. That's why you will have to have anticoagulation for sixth sinus syndrome. So this is how we can do a pacing, either a dual pacing or ventricular pacing, or you can have rate response dual chamber pacing. So one of these, atrial pacing, whatever it is, depends on desire for asynchrony or synchrony. So AV nodal block, this is what is important for sometimes. AV node functions as a bridge connecting atria and ventricle. So functionally, it helps in conducting the cardiac impulses from originating from SA node to ventricle. So it's a bridge acting between SA node to ventricle. This is AV node. AV nodal block will be there. So bradyarrhythmias occur when there is conduction slowing or conduction block is there in the AV node. Delay or interruption in the conduction of the impulses from the atria to ventricle, either due to functional or structural abnormalities, which may be a transient or permanent. So delay in one of these, interruption of the conduction of the atrial to ventricle, can produce AV nodal block. So there are three types. Depending on the severity, it is classified as three types. One is first degree, second degree, third degree, and one more is high grade AV block. So causes are, I said you, is a Lennox disease, infection, autoimmune disease. There are many causes: metabolic, drugs, infection, congenital, inflammatory, and degenerative. Mainly in the old age people, as I said, coronary artery disease, acute MI, right? So Leber's disease, Lennox disease, so many can produce AV nodal dysfunction. First degree AV block, a delay in the conduction of impulses from the atria to ventricle without interruption of the conduction. There is a delay, but the conduction is not interrupted. It goes on. So on ECG, it appears as prolonged PR interval. It's just a prolonged PR interval over 300 milliseconds. In a second degree AV block, intermittent failure of the conduction of impulse from atria to ventricle. There is intermittent failure. It is either 2:1 or 3:2, whatever it is. The conduction failure will be there. So it can be divided into two types. One is Mobis type, that's Vankenbach's phenomena, and Mobis type 2, second degree AV block, right? Coming to first degree, that is Mobis type 1 Vankenbach's, you can see there's a progressive increase in the PR ventricle, and then there is a drop in the beat. So there is a loss of ventricular complex. So as the progression of the PR interval increases, there is a drop in the beat. The shortening of the RR interval, each prolongation of the PR interval, the RR interval becomes closer, and this is also called group pattern. So all RR intervals come into one act, and they are called group pattern type. So this is a pause that less than 2 times of the preceding RR interval. So this is the Vankenbach's phenomenon. So Mobis type 2 block. Mobis type 2 block is an intermittent failure of conduction of impulses from atria to ventricle. But there is no change in the PR interval. There is no change in the RR interval. So this is what the difference can be made between the type 1 Vankenbach's phenomenon and the type 2, right? The complete heart block, otherwise called as the slow AV dissociation. It is characterized by complete failure of the conduction of impulses from atria to ventricle. There is no relation between P waves and the ventricular QRS complex. So there is not. P waves contraction is unknown, QRS is unknown. So because the block, the complete block is there. So but the P wave is constant. There is a constant interval of P wave. Sometimes atria rate may be there than the ventricle, or sometimes ventricular rate is maybe more. So this is the characteristic of the AV dissociation or a complete heart block. So this looks like constant PP interval, 1 P to other, but the ventricular rate, some atrial rate may be more, right? So the atria is contracting on its own, and then the ventricular is contracting. There is no relation between P and the ventricular complexes. Another type is high grade. This falls between second and a third degree block. Here, some of the P waves are conducted. Intermittent P waves are conducted to QRS complex. The ventricle is acting. So intermittently conduct to the ventricles, producing ventricular contractions. So how do you treat this? Initial step of the management is with AV nodal dysfunction as follows. One is stabilize the hemodynamic status. You should stabilize either with your inotropes or with your anticholinergics. Whatever, stabilize the hemodynamics. Reversible causes, particularly drugs, prescribed AV nodal dysfunction should be removed. Correction of electrolytes, various electrolytes, mainly the potassium. So these electrolytes abnormality should be corrected. Treat myocardial ischemia or infarction, whatever it is there. And pharmacotherapy of this is atropine, isoprene may be necessary. The block is in AV node. Withholding the drugs that inhibit the AV nodal conduction. This is the treatment for the blocks. This is the treatment for the first and second, third degree blocks, right? So pacing is necessary when there is refractory to pharmacotherapy, or the initiation of the pharmacotherapy is delayed when you need to be paced early, then can be done. Either it can be done temporarily or permanently. Temporarily can be done by the transvenous or transcutaneous pacing, right? Then the permanent pacing is incision of the permanent pacing may be considered if the AV dissociation or symptoms persist in spite of the medical treatment. So AV dissociation is one ideal indication for the permanent pacing. So with all these things, probably I'm in time. I have not exceeded my timing, I feel. Development of cardiac arrhythmias perioperative period results in a hemodynamic abnormality. We should be taken care early treatment. Perioperatively, intensive care monitoring should be needed in the lead 2 and lead 5. So one should have proper knowledge of both electrical and pharmacological options available to treat. So thank you very much.
Thank you, Dr. Ravi. You have comprehensively dealt with all the features of different types of arrhythmias and their recognition. You should project, I think, some quiz questions now. Will you do it now?
Yeah, Ravi sir, can you project the quiz questions?
Yeah, I'll do. They are there in the open.
Yeah, meanwhile, Avati sir, can you unmute yourself?
Yeah.
And maybe you and Kodanram sir can add some.
Yes, sir.
The discussion. Yeah, Avati sir, and you can also add to the discussion, sir, till Ravi sir puts up the quiz questions on the screen.
Yes, sir. This arrhythmia is very important for anesthetist. As such, after cardiologist, the anesthetist is the main person who is dealing with cardia, sir. And I am proud to say it because every day, immediately after giving spinal or general anesthesia, what we deal is the mainly cardia. So arrhythmias are very important because any arrhythmia ultimately results in hemodynamic changes, which we have to monitor. And the etiology of that one remains in the arrhythmias. So if we know the management of arrhythmias, then only we can be a good anesthetist and we can give a good result for the anesthesia. So the need for knowing the basics of the arrhythmias is very important, and Ravi sir has told it very nicely. We are very happy to say it. And it's about today you arranged it nicely, and we have joined Zoom meeting, and we are quite comfortable with the arrangement, and we are seeing you very nicely and clearly. We are thankful for you, sir.
Thank you, sir. And Kodanram sir, I think Gurudat sir has nicely answered some of the queries that have been already put in the chat. So maybe which remain unanswered, you can put it to Ravi sir, and maybe Ravi sir can answer them. Or if moderator themselves have any questions to ask Ravi sir, please go ahead.
No, sir, there is nothing to ask, sir. We're happy he has done quite comfortably as a good anesthetist. And Gurudat sir has corrected. I have also seen, sir. And I don't want to highlight here, sir. Let Ravi sir highlight it.
Yes.
So some of the
Ravi sir, you are able to share this question, sir? Or
yes, you can see that?
No, sir. Please share the screen, sir.
Share the screen.
Kodandram sir, you want to add anything till he's sharing the screen? Okay.
Yeah. So I have a question with the audience, the students. What are the causes and ECG findings of AV dissociation?
Postgraduates can take 10 to 15 seconds to answer this, and then Ravi sir will show the answer. Is that correct, sir?
Yeah.
Okay. Just give them 10 seconds and then we can go with the answer. Please type as question 1 and answer, those who are participating in this. It is not like an MCQ, but whatever, I think you can type the answer. So what are the causes and ECG findings of AV dissociation? Okay, Ravi sir, I think you can proceed with the answer. I can see your answers in the side. I think people are also able to see the answer because you are not done full screen.
Yeah.
Okay. Yeah, we have main causes here are, one is complete heart block, that is 30-degree heart block. And then the VT, ventricular tachycardia, can also produce an AV dissociation, in fact. So this is if the students know these two, I think it is fine, right?
So we wanted them to answer correctly so that we can give them certificates. Anyway, please go ahead, sir.
So have the answer about the ECG?
Yeah, please go ahead, sir. You already shared the answer. ECG. Okay.
This is an ECG of the AV dissociation. You can see the ventricle is contracting on its own, and then the atria is contracting on its own. You can see the RR interval, varying of the RR interval, and then the P waves, and then the QRS complex on its own. So that's what the classical findings of the 3rd-degree AV block. Can we?
Yeah, go to the next question, sir.
So what are the ECG changes in type 1 2nd-degree AV block? What are the ECG changes in type 1 2nd-degree AV block?
Yeah, please type as question 2 and then your answer. Those who are participating in the quiz. Those who are not using their name but the phone's name, please type your name as well, because it's very difficult to identify from the phone the individual's name. Yes, sir. Please go ahead, sir. Ravi, sir.
Look at this. Mobius type 1 Vankenbach's, and there is the prolonged PR interval. Every time the PR interval keep prolonging, and there's a drop in a beat. There is a escape beat. The ventricle dropped out. Missed beat are there, and then the AV increasing delay of AV nodal conduction until P wave fails to conduct through AV node. Progressing PR interval prolongation with each beat until a P wave is not conducted. There is an irregular RR interval. You can see the RR interval, varying RR interval. Sometimes these blocks can be called as a group beating. The QRS complex, as the PR interval increases, the QRS complex come together. This is also called group beating. So these are the 3 main findings you can see in the Mobius, that is Vankenbach's phenomenon.
I think you have one last question, no, sir?
Yeah.
Yeah, please, sir.
Can somebody read this ECG?
So you can share the answer, sir.
Yeah, and just tell you, I did not type it. This is an acute anti-eval STEMI. You can see the V2, V3, there is an ST elevation, V2, V3. And then also, this why we say acute is, there's, you can see hyperacute T waves. In all the leads, in all the chest leads, most of the chest leads, V2, V3, and V4, you can see hyperacute T waves. This hyperacute T waves in the acute coronary syndrome indicates the infarction is going on. It started on. And the difference between hyperacute T waves and then hyperkalemia is the T wave is broad. You can see the T wave, broad-based T wave. But in hyperkalemia, the tall and narrow QRS, I mean, not narrow T wave. The postgraduates can take this. There is hyperacute T wave, the broad T wave. It tells you about the hyperacute, the myocardial infarction is on the way, is acute. And then ST elevation, anterior ST elevation is there, right? That is the difference you can make between hyperkalemia and hyperacute T waves.
Thank you, sir. And I will go through the chats and identify who have answered them correctly, and will announce maybe after the second presentation.
Yeah.
Kodandram sir, Balbhaskar sir, and Avati sir, please. If there are any questions which are left unanswered, or if anyone have questions, please go ahead.
In fact, one of, as you say, Dr. Sri Ganesh, Dr. Gurdat sir has been giving a lot of hints about, hints in the sense he has expanded upon many points brought out by Dr. Ravi, the speaker. But what I would actually want Dr. Kodandram sir also to contribute is about the most simple and the basic dysrhythmias which a resident would be seeing. For example, at the time of intubation, number one, or immediately after spinal anesthesia, number two, or number three, when there is some laparotomy procedure that is going on, or there is a cesarean section going on. So these are more practical things apart from being able to diagnose, in the sense that there are a lot of factors which have to be first considered as precipitating factors before you think of managing them. Sir, Kodandram sir, what is your take on this, sir?
Exactly, yeah. See, these arrhythmias, intraoperative arrhythmias are in fact very common. Yes. We may come across in many of the patients once we put the patient on continuous electrocardiograph display. We see the arrhythmias, but all of them are not lethal. Only some are lethal and require treatment. Like Dr. Ravi was telling, when there is hemodynamic instability or when there is imminent danger of going into a cardiac arrest or dangerous arrhythmias, then we have to treat. The commonest ones we come across very almost on every case we come across. Like in general, we come across during induction or intubation, we come across sympathetic overactivity. So we come across multiple atrial extrasystole. Likewise, we may also have premature ventricular extrasystole also. Both of these are very common, especially under general anesthesia. If you take the spinal anesthesia, very common due to the Bainbridge reflex, we come across sinus bradycardia. So this is the commonest one. And in general, what I want to say is in general anesthesia, usually the heart rate goes up. And likewise, under regional spinal or epidural anesthesia, the heart rate will be usually on the lower side. So I want to say that if there is tachycardia under spinal or epidural anesthesia, you must be very cautious. In the same manner, if there is bradycardia when a patient is under general anesthesia, you must be very cautious to know what the possible causes are. And again, another very important thing is about the influence of autonomic nervous system, the vagal reflexes. The vagal reflexes are very strong causes of arrhythmias. I recount a case of imminent cardiac arrest which occurred on the table when the tip of the appendix was just lifted by the surgeon under his spinal anesthesia. The patient was about 17-year-old law student. So the moment he lifted the tip of the appendix by back of the girl went into imminent cardiac arrest and had to be treated when an open appendectomy was being done about 15 years back. So this is the influence of vagal reflexes. The local anesthetics as drugs are not by themselves very safe, especially in the hands of surgeons. For example, they infiltrate unknown amounts of adrenaline in ear, nose, and throat surgery, dental surgery. So again, I can quote the example of a particular case. After thyroidectomy, the surgeon infiltrated the bed of the thyroid after the surgery is over with bupivacaine, and in no time, within a minute or so, patient went into irregular rhythm, conduction disturbances, bradycardia. Fortunately, no hemodynamic instability was there, and the patient survived. So this is due to vascular absorption. It is a very vascular area, thyroid region just operated. So you must be very careful about the use of local anesthetics also. Iatrogen, these are iatrogenic. So reflexes, vasovagal reflexes, or use of drugs, including anesthetic agents and other drugs, which will affect the conduction system, the heart. They are all very important, which we must keep in mind practically in the management of the case. But one important thing which I want to mention is though in most of the hospitals we are having these monitoring facilities, still the age-old dictum of finger on the pulse is very important. Why I'm telling you this is sometimes we come across these artifacts, and when these artifacts are there, if you have finger on the pulse, you will be able to find out whether the rhythm is all right, whether the volume is good or not. So the finger on the pulse is very important monitor, which you must keep in mind. In fact, earlier, many years back, I know how the over-enthusiastic juniors have started CPR when the patient had a flat line on the ECG monitor, thinking that the patient has gone into asystole. Actually, the leads were disconnected. So such things, funny things will happen if we don't look for these artifacts and other such disturbances. So with the present availability of the resources and also technology, one more thing which we must keep in mind is it is prudent and essential that we must keep ready for both defibrillation and also pacing, which Dr. Ravi has enlightened. So these are my comments.
There is one more. Thanks a lot for very succinct, because it's very common practice that we have this type of bradycardia, dysrhythmias, which we observe for basic management. And of course, Dr. Ravi has given an exhaustive account of the overall ECG management, apart from the etiology. But I would like to address this to Dr. Gurudat sir here. What should we be looking at in terms of technical aspects of an ECG monitor on the screen? Is it just you connect an ECG and keep quiet, or are there some important options, facilities which must be checked for, should be made available in the ECG monitor, rather than just like that, look and think I am a master, I can diagnose many things just looking at the waveform? Sir.
The main thing is, whenever you want to connect the patient to an ECG monitor, first check whether your monitor has got a only limb lead ECG, or it also has got a chest lead ECG, because majority of the older ones had only limb lead ECGs, like you could have only lead 1, lead 2, lead 3. Now presently the modern ECG monitors, you can even have chest leads. So that is very important. Which lead you have to select is very important, because now we always select lead 2 for dysrhythmia management, and also the chest leads, especially the V5 for the ischemia management. So it is very important. what lead you are going to select. The other thing is, again, the amplitude. So many times what will happen is the ECG, some of the patients like obese patients, emphysematous patients, the amplitude of the ECG may be, or the R wave may be very, very low. So then in the beginning only, you'll have to increase the amplitude on the monitor so that the arrhythmias can be easily detected. So these are some of the very important things when you start your the monitoring of the patient, and especially the lead 2 and V5 are very, very important, monitoring leads. And suppose if you have only the limb lead ECGs, like, many of the practitioners, when they go to the nursing homes, you may have only the limb leads. So in such monitors, it is always, you can still monitor the chest leads, especially the V5, just altering the limb lead 1. So you just go to select the limb lead 1, and then, you have a right arm electrode and a left arm electrode. So you keep the left arm electrode over the V5 position, and you keep the right arm electrode depending on your convenience. If you keep it just below the clavicle also, you will be getting the V5. You can keep it over the manubrium sterni. You can also have the V5. It is also called as CS5 and CM5. You can keep the right arm electrode on the back. It will be CB5. So these are very, very important, because what is the purpose of monitoring the ECG, whether for ischemia or for dysrhythmias? So these are the few things which you should always remember about.
So thanks a lot, sir.
I think Ravi sir wants to talk. Ravi sir, can you unmute?
Hello?
Yeah, can you hear me?
Yeah, please.
Yeah, adding to Gurudat, sir, the pre-existing cardiac disease like coronary artery disease and any patients with mitral valve disease, these patients require to have some of the chest leads so that we can calculate and take a decision with the ECG readings. Definitely, we can come to a conclusion what phase we can treat, how best we can urge for the treatment. Definitely, we can make it out. We add for the word, we'll have to have a chest leads also in a pre-existing disease like this.
So in fact, to add to what Dr. Ravi and Dr. Gurdas sir is telling, basically it is, yes, we have to check for the proper lead placement. We should look for standardization. We should look for correct voltage settings for the particular patient. And basically, as sir was telling, some of the lead placements for arrhythmias specifically, some lead placements specifically for ischemia detection. In fact, there are so many placements which are described. In fact, PGs can just play around. So whenever they are on the OT table, keep shifting the electrodes. You are going to get different pictures, in the sense attributed to different parts of the left ventricle and right ventricle. As he says, even CM5, CS5, CB5, they are on the back, they are on the forehead and everywhere. So what it means is, it is just a matter of getting the signals of the cardiac activity, trying to find out the waves. So these are the ones which we must know. But one thing is, there are many modern, and they are part of the modern ECG machines. They are very important, because arrhythmia detection is one which is very important for us to know. Number two, second is ST segment analysis, because just looking from a distance at an ECG, I told in the beginning, will not be getting an idea. From a distance, I may say, hey, there is an ST segment elevation, there is ST segment depression, but it will be only apparent. It will not be the right one. So what we should do is, we should exploit the settings which are present within the ECG monitor, which gives us exactly how much is ST segment depression, elevation, J point, and other things. Yes, sir. Ravi, sir.
Yeah, adding to you, that's right, Balavaskar. Yes. When you look at the ST segment, you should always look at the isoelectrical line.
Yes.
So there are so many false positive readings when you're reading a ST segment elevation, as I said. So all the postgrads, the isoelectrical line. So down the isoelectrical line, up the isoelectrical line, you have to take an ST segment decisions.
Yes. Yeah.
That is what my view.
Correct measurements are there available in the majority of the modern monitors. In fact, it is advisable to go through those settings in the monitor and decide on diagnosis of possible ischemic episodes in the peri-op period and dysrhythmias. And just probably, Shri Ganesh, I want one question to our legal advisor, Dr. Shivkumar.
Shivkumar sir, can you unmute?
Yeah.
Yes, sir.
Please unmute. Yeah. So just monitoring using an ECG for medico-legal purposes.
Yeah, it has some medico-legal implications because when the court asks you to produce whether you have identified the arrhythmias at the right particular point of time, whether you have treated it or not. So sometimes if you are monitoring it, probably you can take a strip and produce in the court of law what the arrhythmias you have done and what you treated it. Just because if you are not noticed arrhythmias in particular point of time, if you see only the flat line, probably it shows that you are negligent in detecting the arrhythmias and you have not acted upon that. So it clearly shows that there is some mishap intraoperatively which you are not, substances which you are not identified and treated it.
Can I go a little bit further, or is it so for us? Should we
please.
be keeping a trend of the ECG? Because make sure that the battery backup is good, and majority of the ECG monitors have got trends of 2 hours, 4 hours, up to 24 hours. Is it important for us to maintain a trend of changes so that we can say we have detected on time, we have managed on time, we have done everything perfectly, but still we could not save the patient?
Definitely that trend has to be inculcated and has to be adopted by all the hospitals.
Okay, so it is part of monitoring, but medico-legally it becomes very important for us.
Definitely, it is a very good role, because since it's especially in the new consumer act, lot many things are adopted, and it makes a lot of difference to fight.
Okay. So, Doctor, we have got Shriganesh, we have got seniors along our group. Would you want to address them, or shall we go to the next topic?
Meanwhile, there is one question from one of the participants. This is if a patient is undergoing neuraxial block and pre-existingly patient had some sort of arrhythmia, then what will be your approach to the patient, Dr. Ravi? Like, for example, maybe having a very low heart rate. Basal heart rate itself is 50, 52 like that. So
sometimes this basal heart rate can be physiological. Basal heart rates in obese people and in athletic people can be less. So we should know what is the stroke volume without bradycardia. If the stroke volume is fine, if the basal heart rate is around 50, 40, the stroke volume is fine, if the pressure is maintaining, that is, don't have to worry. That is not pathological, it's a physiological. If you consider pathological, if the bradycardia is pathological, then you will have to treat, and you will have to intervene and treat either with your medication, or you are correcting the causes could be done, then you can take.
In such cases, would you advise to give the patient a pre-medication with atropine and then go ahead with spinal anesthesia, or
that would be better? That would be better. But you will have to know why the bradycardia is this physiological or pathological. If it is really physiological, stroke volume is good, pressure is maintained, not to worry about it. If it is pathological, say bradycardia is due to some other cause, you have to find it out and start with pre-medication atropine, as you said, and glycopyrrolate, and treat the cause, then you can take for a neuraxial blockade. My view is that.
Thank you.
Balbasa sir, you wanted to tell something, I did not get you. Can you repeat, sir?
So I could see our senior most faculty also among us.
Please invite, sir. I can see Venkatagiri sir, I think Kameshwar sir.
Dr. Gangadhar sir is there, Dr. Marsu sir is there. So I would request them to please join the
please unmute
discussion.
Dr. Muralidhar Kanchi is also there. Please unmute, sir. Arsur sir, please unmute.
Sir is online,
please, sir. Go ahead, sir.
Sir is there, but I would just specifically probably want him to convey. See, the chest discomfort and the bradycardia which accompanies especially the cesarean section at the time of extraction, sir. So I would want to share your knowledge with our postgraduates, especially this is almost a physiological thing which is very common, apart from what we see with respect to the vagal reflexes in other abdominal surgeries. Sir?
Arsur sir?
Yes, sir. Sir.
It was a nice presentation, Dr. Ravi. It was really, you have simplified the topic, such a vast topic. But what I would like to convey to our younger colleagues is whenever we look at the ECG, we look at only two things inside the OT. One is what is the rhythm and what has happened to the ST segment. These are the two things. And those two things we should look at with reference to the anesthetic implications. Like what example you said, a full bladder or a baby extraction during extraction or an appendix, like Dr. Kudandram was telling. So with that reference, we have to see. And occasionally we come across, say, like a hyperkalemia or such situations. So therefore, what we see normally in a ECG in a medical ward or a medical ICU will be slightly different from that in the operation theater. And so that way we should have a, like what you said, the trend is very, very important. What was the baseline? And from there, what is the deviation that has occurred in the intraoperative period? And what are the specific causes for this particular deviation? That is, most of the times it is arrhythmia. Or ST segment changes are there, then those things can be looked upon. So that's just I wanted to share those things. Otherwise, Ravi has made the job very much simpler to everyone.
Thank you, sir.
Sir, I was just addressing.
Want to add anything or?
Yeah.
No, I was addressing a small question to Arsur sir.
Okay, please go ahead, sir.
In fact, there was a, as he was speaking, there is again a question related to that. One is, yes, during cesarean section,
yeah,
one commonest manifestations which we might see is just around extraction. Initially, there is extremes of tachycardia. In the sense, heart rate increases almost like SVT. That is which many of us would have observed. And later on, as the child is being extracted, we get some bradycardiac response with chest discomfort and all. Yeah. So this is, I think normally, yes, it is what is expected in cesarean section. I want you to please expand for our postgraduates, sir, why and how it occurs, and should we be responding and how we should be responding.
No, first and foremost is I think we must find out whether there is any aortocaval compression, because that is the commonest thing that because the fall in the blood pressure, the heart tries to compensate and by producing a tachycardia. That's the first thing. And we do teach the students, yes, the moment you give a tilt, a mild tilt with whatever 15 degrees we recommend by any method, most of the times the rate comes down. This is the first thing. Therefore, it is whether there is any hemodynamic disturbances have occurred, like a fall in the blood pressure is there in addition to a very high heart rate or something like that. It is advisable not to treat these type of tachycardia, what we see. And the majority of the case, or nearly all cases, do respond with the moment baby is extracted, the heart rate comes back to normal. And yes, some cases there will be a patient may be complaining about chest discomfort and such things. That may be the reason may be quite different for this thing. It may be the handling of the abdominal contents or such things. I do not think it is anything to do with the heart.
Actually, of course, it is not a question to be asked. One of our, in the sense in modern practice, one of our colleagues have asked, sir, for cesarean and a neuroaxial block, whether ECG monitoring is mandatory.
Yeah, definitely. So, it is mandatory. There is no doubt about that.
No doubt about that.
I told you the reason is, ultimately what we do with the ECG is, one, we determine the rate. And sometimes the sympathetic nervous system activity is very high and we do see arrhythmias. Only thing is, see, what we are doing with the monitor is preventing the complications. And absolutely nothing wrong in doing it. Yes, Ravi, please.
Sir, you are right, sir. Most of the arrhythmias that we get in cesarean section are benign. They are very much benign, in fact. And ECG monitoring, as per this, is mandatory, sir. There is no outgoing away from the ECG monitoring. It's a mandatory for all surgery.
Yeah.
Yeah. And then the other thing, sir, when we have seen postgraduates, when they get the bradycardia probably 60 around, they're likely to give a lot of atropine. These things they should be avoiding. They should be careful when giving this atropine. When they get, they should really look at a benign or it is a treatable, because when they give atropine, they should look at the stroke wall and the blood pressure. They don't look at that. When bradycardia is there, they give atropine. They want heartbeat to be more than 100, 110. It will be something like that. That we have very frequently seen in the postgrad, sir.
Yeah.
But the cardiac output is at
Hello.
its best when the heart rate is around between 50 and 60. What ultimately we look for is a cardiac output, and therefore I fully agree that the heart rate should not be disturbed. I think Dr. Gurudatta also is telling, if that is lower than that, if there is a parasympathetic overactivity, in such situations, maybe the atropine premedication is definitely recommended, but not otherwise in a routine cases in majority of the patients.
In addition to what aortocaval compression and its effects which Dr. Harsur was telling, the other important thing during cesarean section is they say the products of conception, some of them escape into the vascular channels, and they are also responsible for producing some arrhythmias. So as the baby is extricated, some of these products are placental products, amniotic products, so they may enter into the vascular channels, and that may be responsible for arrhythmias, is one of the theories. And also the use of drugs, iatrogenic, like oxytocin. So this may also cause arrhythmias. So these also should be kept in mind. It is not only mechanical cause.
In fact, I think Dr. Kameshwar Rao sir has clearly stated, being the past president of IS National, he has said there is no way we can avoid using it. It's not allowed legally also. We must have a monitor, number one. And secondly, defibrillator is mandatory. Sir, Kameshwar Rao sir. Dr. Kameshwar Rao.
Sir, please unmute.
Good evening, sir. Good evening, sir.
Yes, sir. Please, sir.
First of all, good evening to everyone. Good evening, everyone, sir. Very interesting and very important topic to everyone practicing as well as for the postgraduates.
Yes, sir.
And that in the chat box also I mentioned, sir, for every arrhythmia, for every ectopic, they need not bother. Most of the times we see benign ectopics, which we can ignore. Malignant ectopics only we have to take care. That's what I put in the chat box, because in malignant ectopics, they have to identify because they are multifocal, or anti phenomena. They occur in rapid succession. We call it as salvos of ectopics. If these features are present or noticed during the course of the monitoring, they have to immediately act. Otherwise, most of the benign ectopics you can ignore, which can happen during routine anesthesia. That's what I mean.
Yeah. So there is no way we can escape the basics. As Dr. Avati was telling in the beginning, we should be sound in the basics. As anesthesiologists, there is no cardiologist. We are there to just check why things have happened, see the precipitating factors are corrected, then decide whether to treat or not. Treating is only when patient becomes symptomatic or there are obvious hemodynamic problems which are very life-threatening. So these are the conditions. So there is no way we escape. Stop monitoring, starting from finger on the pulse, as Dr. Ravi was telling, and going towards actual final ECG assessment. And
any comments from Dr. Murali Kanchi? He is there.
Murali is there.
Can you hear me?
Yes, sir.
The very nice discussion. I would like to say that
yes.
There is 6-point formula when we look at the ECG. One is what is the rate, regularity, is it a sinus rhythm or non-sinus rhythm? Looking at the P wave, precede each of the QRS. What is the P wave abnormality? What is the QRS abnormality? How is the ST segment? And most important, last point is it life-threatening? So when we go through this stepwise fashion, you may not get the diagnosis, but you will get an idea whether it's supraventricular or ventricular. And you have to identify whether the patient is symptomatic, if it's a bradycardia, and if it is a tachycardia, you have to see whether the patient is stable or unstable. Depending on that, we have to treat. If it is non-symptomatic bradycardia, you just have to watch the patient. Patient's blood pressure is fine, heart rate is fine, heart rate is low, saturation is good. So here you just have to observe the patient, monitor the patient. But if the patient is symptomatic, if bradycardia is associated with hypotension, chest pain, pulmonary congestion, syncope, etc., you have to treat the bradycardia. Atropine is the drug of choice, first drug of choice. If it doesn't respond, you have to go for epinephrine or dopamine. And if available, you have to go for transvenous pacemaker or a transcutaneous pacemaker. This is about bradycardia. Coming to tachycardia, again here you have to see whether the patient is stable or unstable. Stable means blood pressure is fine, patient is conscious and talking, or patient is stable if the patient is anesthetized. There you have time to decide what to do. But if the patient is unstable, the first step is to give a cardioversion or DC defibrillation, depending upon the type of arrhythmia you see. If it is a broad complex, irregular broad complex, you have to go for defibrillation. But in other tachycardias, you have to give a synchronized shock. So this is a stepwise approach. This is what is recommended by the American Heart Association and in all the ACLS guidelines and the AHA training programs for ACLS. This is being taught to everybody. It is easy to follow. You don't have to break the head to find out whether it is AV nodal reentry tachycardia or supraventricular tachycardia or any such thing. As long as there is a tachycardia which is not sinus tachycardia and patient is stable or unstable, depending upon that, you have to treat. If it is stable, you have to go for the adenosine and drug therapy if the QRS is narrow. And if the patient is unstable, we have to go for cardioversion. And as Dr. Balabhaskar has pointed out, defibrillation is mandatory. Defibrillators are mandatory when we are tackling patients like this. Thank you for this opportunity. I'm liking this discussion. Thank you so much.
Thank you, Dr. Murali.
Thank you, sir. Kodanram, sir. I think we are already in 7:55.
Yeah.
Can we go to the next
we will
topic?
go on to the next topic.
Yeah.
Dr. Nazir Ahmad, Professor of Anesthesia and also Director of Pain Services, Bijapur. I invite you to start talking about the next topic. It is a primer on the drugs and techniques used for various pain syndromes. Dr. Nazir, please.
Nazir, sir, please unmute yourself. We can't hear you. You are muted. Yeah, now you are fine. Please go ahead.
Good evening to everybody. Actually, I want to thank the ISA office bearers for giving an opportunity on this occasion to talk on this topic. And most important thing is I have got my 3 teachers here, Guru sir, Harshu sir, and Balbhaskar, my senior, and as well as my teacher. So I want to dedicate this topic to my teachers on this occasion. And pain is this is a new branch in the medicine, which I'm practicing since 2010. Just I want to share my experience, what I'm coming across with the patients. And this is a broad, very extensive topic. I've tried to minimize as much as possible. If few minutes it takes, you try to bear, and I try to restrict to less than 30 minutes. So So topic is drugs and procedures for practitioners. Actually, I have divided this topic into 3, this one, because to practice the pain, you need to have a basic concept of basics about the pain, then drugs used in the pain management, and finally interventions which are used routinely to treat the, control the pain. So as all of you know, because chronic pain management is a difficult entity and a complex phenomena compared to acute pain, but because pain medicine is evolving because of this evolution, and we are seeing a lot of developments in the field of pain medicine, which helps in managing the chronic pain, particularly acute pain. As an anesthesiologist, usually we manage, but as far as chronic pain is concerned, because of this multimodality, it's a bit difficult to manage. So coming to the pain definition, as you know, in recently June 2020, the definition is modified actually. It is an unpleasant sensory and emotional experience associated with resembling that associated with actual or potential tissue damage are described in terms of such damage. Because it is not a sign, it is basically a symptom. So it affects all the population irrespective of the age, sex and ethnicity. And most importantly, what patient says, we have to listen. Here, most of the diagnosis depends upon the patient history. And sometimes pain may be present in the absence of tissue damage, which we are looking for the pathophysiological cause. And considering this definition, and pain is a multimodal actually. It is not what we thought compared to acute. Acute pain is unimodal, and chronic pain is a multimodal. So we divide pain into acute and chronic. Acute pain usually lasts as long as the pain stimulus is present, and chronic pain usually persists beyond the healing period. That is, acute pain is usually 1.5 months, and subacute is sorry. Are you audible?
Yes, sir.
You are audible, sir. Please go ahead.
Thank you. So acute pain acts as a warning sign, on contrary to the chronic pain, which has got no purpose. It leads to the loss of function and significant health and socioeconomic implications. And usually acute pain results from, as a postgrad and anesthesiologist, we know that it is due to stimulation or activation of the normal pain pathway, and chronic pain results from the dysfunctional activation of the pain pathway. So that is the main thing. And usually chronic pain, we find the abnormalities in the generation, propagation, or interpretation of neurological sickness. And it is a multimodal, and acute pain usually responds to NSAIDs and opioids. On contrary, neuropathic and antidepressant medications are used for the treatment of chronic pain. So pain is classified according to these things: duration and temporal pattern, acute, subacute, and chronic. The less than 1.5 months, 1.5 to 3 months, and more than 3 months. Then nociceptive and neuropathic. Nociceptive pain arises from this, that is somatosensory system, mainly stimulation of nociceptors, and neuropathic is due to involvement of the nervous tissue, nerve or nervous system. Again, it is physical origin is somatic and visceral pain. Then based on the etiology, it is classified as cancer and non-cancer pain and ischemic pain. So other classification based on the probable mechanisms. So this is the classification. Any pain when you try to diagnose or take a history, you find that whether it's acute or chronic. Acute pain is easy to treat compared to chronic pain. Again, in the acute pain, so you got this post-surgical headache, all those things, but we treat with the NSAIDs and opioids. Coming to the chronic pain, nociceptive pain like osteoarthritis pain, then rheumatoid arthritis, then you got neuropathic, again classified into central and peripheral. So this is the one which gives a lot of this one trouble to the pain physician in diagnosis and treating. Then you got a mixed type of pain. So this is what mechanism of the nociceptive pain is. Usually whenever the nociceptors are stimulated by thermal, chemical, or mechanical stimuli, there is a transduction occur. That is conversion of conversion of pain impulse into the electrical impulse, and that is transmitted. Then it is transmitted from the nerve receptors to dorsal horn cells, and where second order neuron starts, and it crosses to the opposite side and ascend in the thalamic tract, then ends in the thalamus. This is the first order neuron, second order neuron, and third order neuron. And these are the things which happens: transduction, transmission, modulation, and we are playing our role by modulating the pain. Either it is exaggerated or it is inhibited at this level. We use different modalities to control the pain. If you are having a physiological knowledge of this. Then coming to the pathophysiology chronic pain, in the chronic pain, repeated pain signaling beyond the duration of healing sensitize the dorsal horns. This is the reason for hyperalgesia. That is a increased response to painful stimuli. And there is a allodynia is pain to a non-painful stimulus. Even just touching will cause the pain. These are the two characteristics of the sensitization. That's why any chronic pain lasting for longer duration, patient will have this hyperalgesia, allodynia, then other signs of chronic pain. So how to assess the pain? The most important is history is the 75% or 80% of the work is done with the history. Most of the pain cases are diagnosed in the history part only. So in the history, this is a mnemonic to remember: OPQRST. O means onset, whether it is a sudden onset or gradual onset. Then sudden onset, especially in trauma; gradual onset may be in some chronic conditions, slowly occurring. Then precipitating factors. P stands for precipitating. What makes the patient pain worse and which relieves them? This is the other things we ask. Then comes is the quality of the pain. Whether it's a throbbing pain, aching pain, nagging pain, or burning pain, otherwise numbness, shooting pain, which is found in the neuropathic pain. Then we find out region. R means site of the pain. Then whether it's referred or not referred, radiating, non-radiating. Then comes the severity. Apart from this, we have to ask about that is effect of this pain on mood, because unless you treat this part also, then you're not going to give the good relief to the patient. Only physical factor we cannot treat. This is the physical part, and then comes is the affective part. Mood, patient may be having depression, anxiety, or sometimes patient may say suicidal tendencies, especially trigeminal neuralgia, or this because chronic pain leads to depression, and depression is again, depressed patient will have pain. So they are interrelated to each other. So we have to find out whether it has got effect on the mood, then family and social life, and its effects on the occupation. Then how pain is measured by the pain scales. Then examination should include general physical examination we do, then examination of the male joints, like from top to bottom, neck, then shoulder, then hip, knee, and spine. Then investigations we ask depend upon the based on the condition patient is presenting to you. So this is the pain intensity is measured by, this is a unidimensional. It measures only severity of the pain, other components of the pain, that is biopsychosocial. So visual analysis scale, everybody knows this is a line. One side it is no pain, other side this one. Next is the NRS. It has got 11 parts, 0 to 10. 0 is no pain. Then in between is moderate and worst pain. Then we have got pain is described as some illiterate patients. We ask mild, moderate, severe. Sometimes we use face scale for measuring. This is practice wise. For practical purpose, it is used. For research purpose, we use multidimensional, but that I am not dealing here with. Now coming to the, after taking history and examination and you come to a probable diagnosis, then how to management of the pain is the important. We have got 4 options now. Unimodal treatment, where a single physician is treating with single therapeutic intervention. For example, a physician is advising opioids, or advising NSAIDs, or advising antidepressants, or physiotherapy is advising the physiotherapy for pain. But multimodal treatment, more than one treatment is used simultaneously with the different mechanisms, because I'll be using antidepressants for different antidepressants here used for not depression. It's basically for as analgesics in the low doses. So antidepressants plus NSAIDs, sometimes muscle relaxants, different mechanism. We use different modes by a single. Again here also single discipline, and one person is advising. Now coming to the multidisciplinary, here more than one person is involved in the management of the patient, like physiotherapist, pain physician, then comes a psychologist. All these 3 people are treating the patient separately, but they are not coming in contact with each other, with their goals. Now the last one is the interdisciplinary treatment, where all the disciplines, like different discipline physicians or treating persons come under one roof and assess the patient from beginning. Then they coordinate with this one treatment modality and they start. This is the best option for, but that is not practically possible in Indian setup, because we are one-man polyclinics are more common in India, so pain clinics. But ideally, interdisciplinary treatment is ideal for comprehensive treatment of chronic pain. So the drugs which are commonly used are NSAIDs. I will not go into detail. They are classed as COX inhibitors, non-COX. Then most important to keep in mind is you should not advise NSAIDs for longer duration, because they will have nephrotoxic, cardiac, and other side effects. And most of the patients to come, I have seen people coming with the renal problem, cardiac problem as a indiscriminate use of the NSAIDs. Usually pain physician we advise for 3 to 5 days. That is after excluding the contraindications. They are useful for nociceptive and inflammatory pain. So these are the depend upon the half-life. We use BD or TID, and the most important thing is pain relief should not be SOS. Like whenever you want to treat the pain, whether acute or immediate post-traumatic, you advise the drug in a based on the half-life. Like some drugs are BD, some drugs are TID, some drugs are once in 24 hours, and usually give up to for 5 to 7 days. Beyond after that, we change over to other drugs. So these are the side effects, which is most common is cardiac like hypertension, edema. Most of the patients, majority of patients with NSAIDs, they come with the puffiness or swelling of the face. That is because of the retention of the sodium and water electrolyte imbalance. So usually, because of this, most of the patient doesn't want to continue, and usually we don't use also. We go for other drugs, safer drugs. So now coming to opioids, in the opioids, they act on the depend upon their classification. Some are agonist, some are antagonist. But in pain practice, these are the 2 drugs which are commonly used. That too in a patch form. Fentanyl patch usually we apply every 3rd day, and it acts on two mechanisms. One is the dorsal horn cells, as well as it inhibits stimulates the inhibitory pathway. Thereby, it modulates the pain at dorsal horn cells. And usually, commonly used in cancer pain and post-operative pain. The another drug which is available patch is buprenorphine patch. This is available as 5 microgram, 10 microgram, and 20 microgram per hour release, and usually it lasts for 1 week. So this is also used for mild to moderate pain. Fentanyl is used in the severe pain, and this is mild to moderate, sometimes as a adjuvant with the other drugs. Now these are the drugs which are in practice now. We use it for longer duration. So they have got dual action. One is they are mu agonist, thereby it causes analgesia. Another effect is they inhibit the reuptake of serotonin and norepinephrine. As a result, so they produce inhibition of the ascending pathway of the pain. So usually the tapentadol is better than tramadol in as far as side effects are concerned. So it is used in the dose of 50 to 100 milligram TID or 1 milligram per kg body weight. So side effects are usually dizziness, nausea, sleepiness, and dry sweating. We are usually giving along with the important group of drugs which pain physician handles actually for the neuropathic pain.
Nazir sir has lost the internet connection. He'll join us back.
Okay.
Yeah, sorry. I'm back.
I think Dr. Nazir has lost the net.
Okay.
So meanwhile, can we may have some announcement, because we have two important announcements.
Yes.
One is we are ISA Karnataka is having next month's webinar. I will just share the screen till Dr. Nazir gets ready. So next month, that is on 12th, we will have the 6th monthly academic program from Belgaum. The first topic is lung isolation techniques and management of one lung ventilation by Dr. Rajesh Mane, professor and head of anesthesiology at JNMC Belgaum. And the second topic for the practitioners is regional blocks in private practice, practical tips by Dr. Rajesh Latkar, private practitioner of ISA Belgaum City branch. So please do join us next month, second Thursday, that is 12th of November. And the next
Nazir
is...
sir has joined. Yeah.
Okay, I think then we'll wait. Nazir sir, you can share the screen. Yeah, there is one more important announcement to be made by our president. Please, I request, we will do that immediately after the presentation. Nazir sir, go ahead, please.
Are you audible, Ganesh?
Yes, please go ahead, sir.
Hello.
Please go ahead.
So coming to the neuropathic medication. So these are the drugs which are used by the pain physician. So most common drug is the carbamazepine, which is used in the treatment of trigeminal neuralgia and classical neuralgia. Dose is from 200 to 1200 milligrams in the incremental doses. It is given in the beginning BID and TED. So we have to keep it in mind while giving this drug. So it's the best drug actually, but in very rarely it can cause severe reactions like Steven-Johnson syndrome and other liver dysfunction and marrow depression. That you have to keep it in mind while prescribing. Another best drugs we are available with us is gabapentinoids. So both are sharing the same GABA analogs. They act by binding to they act by binding to alpha 2 subunit of voltage dependent calcium channels. So final mechanism is they decrease the release of glutamate, substance P and CGRP. Half-life is 2 to 3 hours, half or 6 hours. And these drugs share the common side effects like mild sedation, dizziness, unsteadiness. Then dose is for gabapentins 300 milligrams to 3,600 milligrams, but maximum dose that is we give starting with the 300 OD, BD, TID, and pregabalin is started with 25 milligram, then gradually increase, then reach up to the 600 milligrams. So this is used in the treatment of diabetic neuropathy, trigeminal neuralgia, post-herpetic neuralgia, CRPS, and other chronic pains. So other class of drugs is antidepressants. Those are the amitriptyline, nortriptyline, but commonly because of the side effect, we go for nortriptyline. That is in the dose of 25 milligram, then gradually increase to 100 milligram. Beyond that, it is antidepressant, but lower doses it acts as a analgesic for chronic pain. The one important drug is duloxetine. It is a SNRI, that is serotonin and norepinephrine reuptake inhibitor. So this is used in again same conditions, and adverse effects is serotonin syndrome, glaucoma, angle closed glaucoma, and this hyponatremia. The dose is started with 20 milligram OD, then BD. Maximum is 120 milligram per day in divided doses. So now coming to the third important part is the interventions used for the management of chronic pain, particularly chronic pain. So this interventional pain procedure is a part of interventional pain management. That is a discipline of medicine devoted to the diagnosis and treatment of pain and related disorders by the application of interventional techniques in managing subacute, chronic, persistent, and intractable pain. It is used independently or in conjunction with other modalities of treatment. So what are the interventions? Interventions are minimally invasive, non-surgical and target specific procedures. They are used to diagnose and treat painful, therapeutic and prognostic. For example, diagnostic to identify the pain generator. For example, pain is arising from the facet joint, that is contributing to low back pain. We identify from where pain is arising. For that, for example, give median branch block for facet, then discography for which disc is involved. That is a diagnostic. Then therapeutic is, if that is positive, the same therapeutic is to prolong the pain relief, like use of radiofrequency ablation or epidural steroids. Then for prognostic, like identifying whether to identify the definitive procedure is going to help or not. Then sometimes patient factors. They don't want to take tablets and they want immediate pain relief, and they for the demand of the patient for intervention. These are the indications, and usually all the interventions are done under fluoroscopy, with the exception of few. Then they are more accurate and result oriented. Usually you see the result after intervention. Now, who has to do the intervention? The question comes is, now is anybody can practice or some person who's trained in pain? So a pain physician is the right person for managing all types of pain. So he's a specialist with special training in evaluation, diagnosis and management of all types of pain, both acute and chronic. Then he has got in-depth knowledge of pathophysiology of pain. Then he's able to evaluate different patients with different pain. Then he know how to analyze or interpret the diagnostic test advice for the pain. Then most important is he'll be prescribing the different medication, and he has got skills to perform the interventions. That is in the form of nerve blocks, spinal injections, or other interventions. Finally, he will be a leader in coordinating with other specialists like physiotherapy, psychological therapy, and rehabilitation to provide multidisciplinary approach to the pain. Now, these are the pain syndromes which is commonly across by the pain physician. So most common is myofascial pain syndrome. Another thing is low back pain, then headaches, post-operative neuralgia, sometimes vertebral fractures, then ischemic pain like lower limb thromboangiitis obliterans, or pain in the lower limb because of the arterial atherosclerosis. For that also, pain physician is providing pain relief by giving long-term sympathetic blocks. So what are the interventions? These are the intervention in the order of increasing complexity. This green is simple, doesn't need much of that, anybody can perform. Next is it is an intermediate complexity where facial joint blocks, then epidurals, radiofrequency ablation, celiac plexus for block for the cancer, then more higher complicated process are epidural adenomyosis, then vertebroplasty, kyphoplasty for vertebral fractures, then intrathecal drug delivery system for advanced pain management and spinal cord stimulation. Finally, nowadays pain physicians also doing percutaneous discectomies. So what is the general principle we apply is always we discuss with the patient. You have to discuss with the patient. So what is the advantages of the procedure, side effects, alternatives, everything should be discussed with the patient, and with the consent of the patient, we proceed with the procedure. Otherwise, procedure is not the only way to treat the or control the pain. So investigations usually will have routine investigation to infection, rule out infection, coagulation level should be normal. Then his kidney function should be normal, and informed consent is taken. Then standard monitoring is like for any anesthesia, like ECG, NIVB, SpO2. It is continuously monitored during procedure. Then guidance is must, either in the form of fluoroscopy or nowadays ultrasound machine also we are using for musculoskeletal problems. Then strict aseptic precautions are taken. For any invasive procedure, IV antibiotics are given. So contraindications are, these are the contraindications. So which is for any regional technique. So this is the armamentarium of the physician. So a well set up OT with the CM, then a radiofrequency ablator, generator. Then if ultrasound is available, well and good. Otherwise, with these two things, we can provide good number of pain relief for different pain conditions. Now, what is a radio frequency treatment? It is a high frequency current. It is a radio frequency generator. It has got 4 channels. Some are available as 1 channel. That means you can provide lesion. You can perform lesion for 1 nerve. But in this case, it is 4 nerves can be lesioned. So high frequency current is applied to a neural tissue through a closed circuit. So current is passed from the active electrode through the tissue into the passive electrode. This is the passive electrode. Then we are ablating or burning the nerve. So there are 2 types of radio frequency. One is a conventional or radio frequency, thermal radio frequency, wherein temperature generated is between 60 to 90 degrees centigrade, and in the pulsed RF temperature is less than 45 degrees centigrade. Usually regeneration is possible here, but here there is a protein precipitation and usually death of the neuronal cell or neural membrane occurs here. So then we have got unipolar and bipolar. So other indication, other uses of wherever sensory nerve is there, we can ablate with the radio frequency. And pulse radio frequencies, wherever muscle motor nerve is there or mixed nerve is there, we go for pulsed RF. So the commonest thing practice in the clinic we come across is the myofascial pain. Myofascial, because either it's overuse, misuse, or disuse of the muscles. Most common myofascial trigger points are found in the neck, then shoulder, then the trapezius muscle, and sometimes in the back. So they are diagnosed by, usually they have pain, then sometimes tight taut band, then referred pain, then local twitch response when you press it, jump strain is seen. Sometimes some patients will come with the tightness or weakness of the muscles. The treatment is trigger point injection. This is how it is done. Trigger point is stabilized between the 2 fingers. The needle is passed through. There are 2 types of treatment: dry needling and wet needling. In dry needling, only needle is passed and break the trigger point. In the wet needling, we use local anesthetic and steroid, or sometimes saline. Or if does not respond, we go for botulinum toxin. So what are the interventions used for the low back is, so they depend upon the causes: facial joint pain, discogenic cause, SIJ pain, herniated. So management is again multimodal, multidisciplinary, and apart from medications, interventions are very useful in bringing down the requirement of medicine and severity of the pain. So these are the interventions: steroids, epidural steroids, then facial joint radio frequency or steroid, then SIJ injections, then for disc procedures, ozone or biaculoplasty, then sometimes rhamocommunicants, block, and endoscopic discectomies. So epidural injection is commonly performed by anesthetist, but in the pain physician, usually he uses different approach. So most common, you can approach this epidural from the three ways. One is interlaminar, transfemoral, third is caudal. So in the interlaminar, usually as anesthesiologists, we used to give 10 ml or 8 ml along local with the steroid, 40 milligrams of triamcinolone. But in transfemoral, we approach the epidural space through the foraminal approach. Then this usually provides the relief for the 3 to 6 months, and you can repeat epidurals 3 to 4 times in a year. So there's no contraindication, and usually there's a good amount of evidence is there for management of back pain with the use of epidural. Who wants to practice pain, they can start with this type of simple procedures in the early part of the practice. So this is the actually this is the transfemoral where arrow is showing the exiting the route, and so through this we'll go. And procedure wise, what we do is we make the patient prone position, then we using AB view, lateral view, and oblique view. This is the oblique view. This is Scotty dog appearance. So we have to get Scotty dog appearance for entering the going close to the nerve root. This is the pedicle, is eye of the Scotty dog, then nose, then ear, superior aortic process. Here needle is inserted in oblique view. After oblique view, we go to the lateral view to final target point. That means it should be in the upper part of the foramina in lateral view, and it should not be go too anterior, because there we get radicular arteries or radicular arteries of Adam Kivis. They are usually going along with the nerve. So if you puncture, you may cause bleeding, or you may inject a drug into this, it may cause paraplegia also. So this is the lateral view. Then AP view, the needle should be lateral to 6 o'clock position. Then finally, after finding out aspirating for CSF and blood, we inject small amount of contrast. This is nervogram. So this is exiting nerve root, and it is the epidural space. So this is the AP view and lateral view. After that, once it is confirmed and no negative aspiration, we inject only 2 ml of drug in that. 20 to 40 milligrams of methylprednisolone or triamcinolone or dexamethasone along with the local anesthetic. It gives immediate relief. So why steroids is, steroids has multiple actions. It is anti-inflammatory. It reduces edema of the nerve. Ischemia is whatever ischemia is there, it is also improved. Then inhibition of the C fibers. Then it stabilizes cell membrane. These are the advantages of steroid. So not where we are approaching the caudal epidural space through the sacrococcygeal ligament. So the capacity of this is around 8 to 10 ml. I mean 10 to 15 ml. We use drug around, if you are using only epidural, 10 ml. If you are doing caudal additionalysis, we use different medications. So this additionalysis is a more advanced procedure compared to caudal epidural. In the caudal epidural, we will give only local with steroid, that too single shot. In epidural additionalysis is indicated for foiled back surgery syndrome, then fibrosis, lumbar sterosis. The main purpose here is to break the adhesions, because most of the patients with previous low back surgery, they come with the back pain after 1 year, 2 years, 3 years. Then this is the one of the treatment modality advised. Again, here procedure here done is, and there is two types of additionalysis. One is chemical, mechanical. In the chemical, we are injecting local anesthetics, hyaluronidase, steroid, then hypertonic saline. In mechanical additionalysis, we are breaking the adhesions with the mechanical device, that is called Rax catheter. See, this is the prone position with the draped. Then a special epidural needle is coming, Coutts needle, that is entered into the sacrococcygeal through the sacrococcygeal ligament. The needle is in the caudal epidural space. Then through that we insert the catheter. Then we inject the dye 5 ml. This is the inverted Christmas tree. This is the normal one. Right, left, all the nerve roots are delineated. But now coming to this one, this is having a filling defects. This filling defect indicates that there is a fibrosis that is broken by using, this is a Rax catheter, and we are changing direction the 90 degrees, 60 degrees. Again, after breaking it, again we inject the dye to see that this filling defect has disappeared or not. Then at the end of procedure, we give in the beginning only we give local anesthetics. Then later we add hyaluronidase 1500 units. Then saline 3%. Hypertonic is not available in India. We are using 3%. So altogether, this is going to help the epidural fibrosis. Now, other causes of the back pain is the facial joint arthropathy. This is common in old people. So each joint is supplied by the two nerves. Suppose L3, L4 is supplied by L2, L3, one level same and one level above. So we have to get the anesthesia to get the pain relief of that particular joint. We have to to block the L4, L5 is supplied by L3. That is target point is at the junction of, this is the I, this is the transverse process, SAP. We bring the needle here parallel to the nerve. That is a medial branch. That is a branch of dorsal nerve. So the needle is placed, that is oblique view, then lateral view, then AP view, and finally after confirming it, then we stimulate the nerve with the sensory stimulation. That means we have to get the concordant pain. That means the pain which was felt by the patient should be felt here also as stimulation, and there should not be no motor stimulation. If motor stimulation is there, means the nerve is more anterior in the intravertebral foramina, and it may cause damage to the motor nerve. Again, we rearrange and do the testing. If testing is normal, then we carry out the lesion with 80 to 85 degrees centigrade. That is called conventional radiofrequency. So this will provide the pain relief for almost 1 to 1.5 years. And if it recurs, we can repeat afterwards. So other causes of low back is SI joint. See, this is the sacroiliac joint. So here it is again under fluoroscopy guidance only, not done blindly. It can be done under ultrasound also. But this is the fluoroscope picture. The needle is in position, and this is the anterior, both the anterior and medial joint lines are delineated. After this, we'll inject around 3 to 4 ml of local anesthetic with steroid. Normally they respond. Suppose if it is osteoarthritis, then we have to ablate the nerve supply of the joint. That is S2, S3, S4, using the radiofrequency therapy. Now coming to the interventions for cancer pain. So most common cancer here is abdominal cancer, then pelvic, perineal. These are the common cancers encountered in the practice. But again, cancer pain management is a multimodal, multidisciplinary. So we for this we usually apply the WHO ladder, but intervention should also be simultaneously started. In the WHO, it is the 4th step, but here, see, usually we should not go like this. Once you start the medication, we should also do intervention in the beginning, early part of the cancer only, so that we can better control. So this celiac plexus block is the most commonly performed sympathetic block for cancers of abdomen. Indication is benign malignant conditions, cancer of the pancreas, then CA stomach, liver, then other cancers up to the splenic fracture. Then benign conditions also you can use. Suppose patient is having a chronic pelvic, chronic abdominal pain, which is not having any organic pathology. That's called functional abdominal pain, or acute and chronic pancreatitis, so abdominal angina, then mesenteric artery insufficiency. These are all, in these cases, pain is relieved by doing this sympathetic block. Then what are the drugs equipment needed is, we need a long GO needle, that is around 15 centimeter, 20 centimeter. Then neurolytics like alcohol, phenol. Then along with that, we use steroid and local anesthetics. So we have got approaches. See, we have to deposit here drug. This is the celiac plexus sitting around the celiac trunk. Then this is superior mesenteric artery. So we can enter from behind, we can come from anterior. Posteriorly, we have got 3 approaches. That is retrocrural behind the diaphragm, transcrural, then transaortic. So except in transaortic, rest of the 3 approaches we have to use bilaterally. We have to block the celiac plexus bilaterally. So if patient is not able to lie prone, then we can approach it from anteriorly using ultrasound guided. So this is the prone position. Then this is a transaortic abort. So this vertebral body needle is passed to the aorta. Then dye is injected. The dye is lining the aorta. So this is 1 needle. Then we have got other procedures. We use 2 needles. So one is on either side at the level of L1. Now this is the ultrasound image wherein celiac plexus is performed in the supine position. This is the aorta, then celiac long needle. Then we are injecting the drug between the celiac trunk and superior mesenteric artery, around 15 to 20 ml. Initially, we give diagnostic block with 5 ml of sensor cane, followed by the neurolytic. Around 20 ml is given in the anterior approach, remaining posterior approaches 15 ml. So this is another block which is used for the pelvic cancers, like superior hypogastric plexus. This is also sympathetic trunk situated in front of the L5. So again, we have got from posterior approach, that is paravertebrally we come, then bilaterally we give, and it is drug is deposited anterior to the L5, and you can also do under ultrasound. Recently, we are doing ultrasound also. So this is the this is the picture where this is the needle is entering from the left side of the L5 vertebra, and this is after dye injected. The dye is covering L5, L4, and S1. So after confirmation, aspirating for no blood and this one, then we are injecting the local neurolytic agent. Neurolytics are used in the cancer pain only, and the rest of the cases we are using local anesthetic. So this is a ganglion impure block is where ganglion impure is blocked for perianal and rectal malignancies. So here this ganglion impure is located in front of the coccyx. In front of that is this is the rectum. So your needle is coming here. You should be very careful. Little further it goes, it can perforate the rectum. That's why we prepare the patient. We make the patient NBM, then bowel preparation we do, usually enema or Gas-X tablets. So these are the indications for benign, like endometriosis, CRPS, then proctalgia, Figax, then vaginal burning pain. Chronic pelvic pain is one of the indication. I mean, in chronic pain, we use this block. So if patient responds, then you can also use either neurolysis or RF for prolonged treatment. Now coming to the most important thing is trigeminal neuralgia. What are the interventions we do? You know all this. Trigeminal neuralgia is a neuropathy condition. It is because of the excitation or irritation of the fifth nerve at the brainstem. So that it is causes are idiopathic, then secondary causes. But most of the cases, more than 90% of cases, respond to carbamazepine medically. And carbamazepine is the drug of choice for treating the patients. If they don't respond and they develop the side effects, then we go for other drugs. Then also they don't tolerate non-compliant, then we think of intervention. So what are the interventions available is percutaneous through the skin, RF lesioning is done, and then balloon compression, etc. These are the first three interventions are done by the pain physician. Then gamma knife and surgical procedure is done by the neurosurgeon. So this is the procedure. Patient is placed in supine position under submental view. The most important thing here is identification of the foramen ovale. See, this is the foramen ovale, that is submental and ipsilateral oblique. See, this is the ramus of the mandible. Then this is the horizontally oval-shaped foramen ovale. So needle is entering into the lateral part of the. That means it is divided into three parts. We want to approach V3, then lateral. V2 is middle part of the foramen. V1 is medial most part of the foramina. This is submental view. Then we, while inserting the needle more deep, we go into the lateral view. This is the lateral view. Final end point is at the junction of petrous part of the temporal bone and clavis. This is the final position. Beyond that, we don't go. If you go, you may enter into the brain matter or a middle cerebral artery is there. So it's a very challenging procedure, but you need a good expertise to do this surgery. So here the needle is inserted 2 centimeter lateral to the angle of the mouth. Then submental view, we go into the foramen using the bone as a friend. Then final this one. After final, we do stimulation to ask that key whether we are in the proper division or not, whether in the maxillary division, mandibular or ophthalmic. So if patient complains of mandibular, means that should be in the lateral most, and patient should get pain only in the mandible, not in the maxilla and the forehead. So then we stimulate, then give 3 lesions, that is 50 degrees, 50, 60, 60, 60 and 60, 70. That means 50 degrees centigrade for 1 minute, 60 degrees for another minute. Like that we do 3 lesions and success rate is almost more than 95%. Complications is, known complication is facial numbness, corneal anesthesia. This we will discuss and explain to the patient before going for this one. Another important intervention is intervention for headache. So this spinopendent ganglion is located in the pterygopendylar fossa, and usually it is attached to the maxillary nerve. It supplies the sympathetic flow to the parasympathetic flow to the face. So patients complaining of atypical facial pain, then chronic facial pain, then headache. So these are the indications. Trigeminal neuralgia, then trigeminal neuropathy, spinopendal neuralgia, then migraine and cluster headache, atypical facial. Nowadays, we are using it for treatment of PDPH. So techniques is there are 2. One OPD technique, one is a invasive technique. This outpatient we use it for diagnosis, wherein we use this cotton loaded swabs and they insert into middle meatus. Then we put the 2 to 3 ml of 4% lignocaine. Wait for 10 minutes. After 10 minutes, the patient pain is relieved. That means the origin is, in that cases, they are suitable for spinopendal block with the local anesthetics, or we can go for radio frequency ablation, conventional or pulse radio frequency. So the efficacy is, it is almost give relief for almost 1 year. So now coming to the shoulder pain. Shoulder pain is also very commonly found in the elderly patients, especially with the diabetes mellitus. So what are the causes? The common osteoarthritis, then rotator cuff tear is very common in younger patients, then tendinitis, bursitis, adhesive capsulitis is also known as frozen shoulder, which is commonly found in diabetic patients. Then bicycle tendency. Interventions available for is intraarticular injection, then bursa injection. Then we have got, if there is a tear, we can do PRP of this one. This is the picture showing fluoroscopic way where the right shoulder joint is clearly visible and needle is there, and after dye is injected, this is arthrogram. After finding this, we inject the local anesthetic steroid if there is no contraindication of steroid. Otherwise, we do hydrodilation. Hydrodilation means we use 30 to 35 ml, 25 to 30 ml of local anesthetic with that, saline along with 5 ml of local, together 35 to 40 ml will make. That will help in relieving the pain as well as distending the capsule. So that can be done either with the fluoroscopy or with the ultrasound. The other procedures we have done is the subdeltoid subarachnoidal bursa injection. Then if there is a tear, partial tear is managed by the vein physician. If the tear is complete, rotator cuff, then we will refer to the orthopedic surgeon for surgical correction. So now what we have got for the knee pain. So you know all the orthopedic surgeons, they are got steroid injection, hyaluronidase injection, then this medication. But intervention part wise, other than steroid, now steroid is almost becoming obsolete because of its adverse effect on the cartilage. Now the options available for this, if other than surgery, is if patient is not willing for surgery, we have got this one, genicular branch, genicular nerve block or radiofrequency ablation. This each joint is supplied with 7 genicular branches, which arises from the saphenous nerve, femoral nerve, then sciatic nerve, then this obturator nerve. So, but we will not block all the nerves, only 3 nerves are blocked. This is supermedial genicular branch, superlateral, then inframedial. This inframedial, supermedial, and these are the 3 branches. First, we give diagnostic block with the 2 ml of local anesthetic. If they respond, if pain relief is more than 50%, then we advise them to go for radiofrequency. If pain relief is less than 50, then they are not ideal candidate for the this procedure. So this is almost provide relief for 1 to 1.5 years. If the patient is not willing for surgery or they want to manage, another option is PRP of the knee joint, where PRP means patient own blood is taken, then that is plasma is prepared from the centrifuge, then we inject the PRP into the joint using ultrasound, ultrasound guided or CM guided, but we don't use steroid here. PRP and genicular branches come together, combination giving good relief, or you can give only for genicular branch ablation. So coming to the complications, every intervention has got its own complications. Some are commonly seen, some are rare, but most common is bleeding, but usually we that respond with the pressure application. Then infection, if you are not taking precautions, then dural puncture can occur because you are going close to the spinal cord. Then nerve injury can happen, then intravascular injection, allergic reaction to the contrast dye we use, then steroid effects, patient can have hyperglycemia, mood changes, and other things. To summarize, chronic pain is a complex phenomena having multidimensional biopsychosocial aspects. A thorough pain history and detailed examination are foundations for rational treatment plan. Then most important is multimodal treatment. Interdisciplinary approach is the method of choice to restore quality of life. Our aim is to relieve the pain as well as to restore the quality of life and functionality. And last one is the interventional pain procedures have revolutionized the pain management now. They are minimally invasive procedures which give permanent long-term pain relief and fill the gap between the medical management and invasive operative management. Thank you. So this is the questions for the audience. Sri Ganesh, are you audible?
Yeah, please go ahead, sir. I think audience, there are 3 questions from Dr. Nazir. Please answer them, and whoever answers first and correctly will be receiving e-certificate of appreciation from ISA Karnataka. Please go ahead, sir.
Comprehensive. The first question is this one. Options are medications only, then unimodal interventions, and multimodal and interdisciplinary approach.
Yeah, we already received the answers, including seniors are answering. Yeah, please go to the second question, sir.
Because I kept one question on the, that means multimodal, multidisciplinary, multimodal is the option. Don't think of only intervention, putting the needle in the back, going to relieve the pain. So every pain physician should have, even I had this idea, but I changed my attitude now towards for pain management.
Okay.
So next question is, drug of choice for trigeminal neuralgia. I think everybody will answer.
Go ahead, go ahead. Just read out, please.
Most common, the drug of choice for trigeminal neuralgia is a phenytoin, gabapentin, carbamazepine, and oxcarbamazepine. The third question is, because this is a commonly done procedure, so commonest complication is diarrhea, hypotension, pneumothorax, and renal injury.
Najee sir, you can give out the answer for the previous quiz question because most of them are already answered. So you can please go ahead. Yeah. Quiz 2.
So,
I think first one you already answered.
Our first answer is multimodal and interdisciplinary approach for chronic pain management. It can give best result. So that includes medication, intervention, physiotherapy, then cognitive behavioral therapy. These are the different options, and psychotherapy. Psychotherapy comes under CBT. So this always you should apply it simultaneously to give a best result to the patients who is suffering from chronic pain. So second question is a carbamazepine, because whenever clinically we diagnose, we put the carbamazepine as the drug of choice. If pain is relieved, that means it is 100% it is trigeminal neuralgia. If it is not responding, means it may be trigeminal neuropathic pain, or it may be a atypical facial pain. So this is one of the diagnoses in diagnosing the trigeminal neuralgia pain. Third question is, answer is hypotension, because hypotension is the commonest cause, the commonest complication, followed by the diarrhea. Usually these two are very common complaints, and hypotension usually it lasts for, that's it is prevented by reloading the patient. Then if does not respond, we give vasopressors, all those things. Diarrhea is also in cases, some cases it lasts up to 10-15 days, some cases 3 to 5 days, but most common is hypotension.
Thank you, sir. I think before we go for the discussion, I will announce the results of the winners of the first presentation quiz. Question 1 is Dr. Sneha S. For question 2 is Dr. Sandhya Ramesh, and question 3 is Dr. Anil Kumar. I'll put it in the chat also. And I'll go through the chats for identifying the correct answer who has provided for this particular quiz, and we'll announce later, maybe after the discussion is over. And before, I think, sir, I'll just request Vijayanand sir to announce about our make the announcement. Balbasa sir, is that okay?
Yeah, I think Vijayanand is there, please.
Yeah, meanwhile, our moderators can go through the chats and just see if the relevant questions. I think most of them are answered by Dr. Akamadevi madam and Pratibha madam. But Kodandram sir and Avati sir can go through the chats to identify questions. Meanwhile, Vijayanand sir?
Yeah.
You can make the announcement.
Yeah,
and
nice.
then I think Venkatagiri sir also wants to make an announcement. So you go ahead, sir. Balbasa sir. Vijayanand sir.
Nice presentation, exhaustive. Good evening once again, everybody. As this year, because of the pandemic of COVID-19, we have postponed our state conference, which has to be held at Shumaga in the month of October. So instead of that, we are doing a virtual conference in the month of December on the second Saturday and Sunday. So this is a unique experience, virtual conferences, which was made to be because of the pandemic, and taking in view of the postgraduates who will be deprived of this year. Postgraduate will be deprived of the presentations, awards, and also in continuation of the curriculum of the MCI and the Rajiv Gandhi University. So we are conducting this virtual conference for postgraduate and also for private practitioners. This will be on 12th and 13th of December 2020. This virtual conference will be announced from this day, and you can start sending your e-papers and e-posters for all the postgraduates in Karnataka from tomorrow by visiting karnatakaisa.org. And there will be award papers from BLD award best paper and also best e-poster from Tumkur, ISA Tumkur. Awards will be presented to these postgraduates. They can utilize this beautiful opportunity which will be missed because there will be no other conferences in state or national because of the pandemic. So I request all of you to participate in large number, utilize this opportunity. You can win many prizes here, and it will be a real great thing. And we'll have chairpersons and experts from all over the India, outside the Karnataka also. So there'll be one hall exclusively for private practitioners also. They can send their research papers, original research papers and case studies to Karnataka ISA org. From tomorrow onwards, it will be open from there. The further announcement will be on the website. You can follow those leads, and also we will be sending the flyers, and registration is compulsory for all, and there will be no registration fees for this. I think
fine, sir. I think that you have covered extensively. All details will be available on the website very soon.
Yeah.
With this, I think Venkatagiri sir, you are there. You can unmute and.
I'm there, sir.
Yeah, please, please, sir.
I'm there.
You want to make an announcement and also any queries on this topic of Dr. Nazir Ahmed? You can please go ahead, sir.
No, he has done a very extensively, very nicely. He has explained that detail. The Kameshwara is the ideal person because he is a pain physician to tell any comment on that more than me, because he is the one who is practicing pain medicine. My announcement is it is my state conference. That is Kerala State Conference on 1st November on digital platform, one-day conference, Sunday. So the registration is free, and up to 20th of this month for ISA members. Anybody, any ISA member can log into the website. It is not Kerala website, isawebcon.in, and register for that. Also, we have free papers. People can opt for that, and both posters and free papers. So request all to join, and we have two types of the presentations by, one is CMA, another one clinical discussion by senior faculty members. So we have kept two halls for that, and one hall for free papers and posters.
Thank you, sir. Thank you very much.
Thank you very much, sir.
Balvasu sir and moderators, please take over.
Dr. Nazir.
Yes, sir. Please go ahead, sir.
Dr. Nazir, you have done a very excellent job. You have covered all the topics under the pain medicine. In fact, pain specialty is a growing specialty which is growing by leaps and bounds and is highly rewarding to the patients. Majority of the pain states require only drugs. Only about 15 to 20% may need the interventions. And some of the common conditions which require these interventions have been highlighted by Dr. Nazir, like the trigeminal neuralgia, backache, shoulder pain, etc. And I think there must be many active pain specialists also among the participants. I invite any of them to make a contribution for a minute or two. Dr. Raghavendra, Dr. Arun, Dr. Iyer. If you
they have been very active in chat actually in the background.
Yeah.
Yeah.
Yes, I think Dr. Pratibha, Dr. Akamadevi have already commented, and I think Kameshwara sir also is very active. Maybe they can add, and then.
Good evening, sir.
Yes, sir. Please, sir. Go ahead.
Yes, sir. Please go on.
Good evening. It is an excellent talk by Dr. Nazar. He covered very well most of the chronic pain syndromes. But I wish to add this regarding cancer pain. There are certain things in palliative aspect also to be covered, but the time given is very short and he covered extensively. So oral morphine is one of the important drugs and a gold standard drug in cancer pain management. And if there is no relief, then we will go for interventions, because from the past 20 years, I am managing pain and palliative care. And morphine is very extensively used in the form of tablets. And most of the other physicians have not seen even the tablets available in different strengths of 10, 20, 30, 60 milligrams. And we start with a low dose and then we'll increase it depending on the necessity. And as he specified, these interventional procedures can be done at any stage for cancer pain. That is a good point he said. And WHO ladder also is a guide, but sometimes the patient will come with very severe pain. Sometimes you have to bypass the first 2 steps and straight away you may have to go with a initial low dose morphine along with an SAID. And if there is a neuropathic component, you can add this neuropathic drugs, what he mentioned, along with a combination of NSAID. And that is another point I wish to add for this. And regarding pain, I advise all the youngsters to learn and practice, because there are many pain schools are guiding and training. And pain, most of the pain directors, even in US and UK, are managed by the anesthesiologists only. This is one field which is not taken over by other specialists, because the anesthesiologists are competent in managing the complications that arise while giving the blocks. They are competent in giving the blocks, and they are experts in resuscitative skills, and they know very good about the pharmacology of the drugs. Because of all these factors, most of the pain directors, even in abroad, are the anesthesiologists. So I advise all the youngsters to make a pain medicine as a side this thing in addition to their routine anesthesia. Thank you very much, sir, for giving me the opportunity.
Hello.
Yeah,
can I add?
Yeah, please.
Yeah.
Please.
Yeah, good evening, sir. It was a wonderful presentation by Dr. Nazir. It was very extensive. I just want to say that anybody who's this is about the intervention part of it, but we also have to look into the pain medicine as a specialty, and how do you get trained properly? Because only if you are trained properly, then you can do justice to the specialty. So it is very essential that somebody who's interested should first find out the aptitude, whether you have an aptitude for this specialty. And if you have, then you should undergo training. Don't take up courses for 1 week, 2 weeks, and then jump into this specialty. So you have to undergo. And fortunately now, earlier days, we did not have the fellowship programs, but now we have started FNB in pain medicine. We have DM in pain medicine. We also have IAPM affiliated fellowship for 1 year. So there are a lot of academic courses which are like structured fellowship programs have been started all over India in many of the institutes. So I think somebody who's interested should really undergo a proper training. And there is a huge scope for this specialty as a career option, especially for youngsters, because this field is not yet saturated. There are very less people, and there is a huge demand of this specialty in all over the world. I would say there are a lot of patients who are there, but we don't have specialists who are trained properly in this area. And anesthetist having the skill of already having the skill of regional blocks can make an excellent career option into this specialty. So that's all I have to say about this.
Thank you.
Thank you, Pratibha, madam. Dr. Akamadevi, madam, you want to add anything? And then we'll go back to the moderators. She is also an active pain practitioner. And Kodandaram sir, any questions left unanswered?
No, all the questions have been answered.
Okay.
There are no questions in the chat.
Just to a curious query for Dr. Kameshwar Rao and Dr. Pratibha and others. So where do they get the referrals from in the beginning of the practice? Is it
Akamadevi, madam, you can answer that.
Yeah, Dr. Akamadevi, if somebody wants to start a youngster, he is having a private practice, he wants to put up a pain clinic. Of course, Nazir is there. Nazir, is it possible to get referrals?
Sir, we get good referrals for a cancer patient. Of course, from oncology department, we get good number of referrals. Okay. And regarding the other pain procedures mentioned, we are getting good referrals from orthopedicians, neurosurgeons, neurophysicians, various epidural blocks. And even now I am giving regularly this lumbar and cervical epidurals in my clinic. I can say it is a backache clinic. I can say my clinic is a backache clinic. Occasionally I will be giving cervical also. And with good number of referrals are coming, sir, from various sources, from various specialists.
Yeah, many times onco-surgeons, they do surgery and they do the pain management to the pain specialist, especially for the anesthesiologist also.
Correct, sir.
And
Failed back syndromes.
Yeah, yeah, even medical oncologists, to a certain extent, they do the curative therapy. But the curative therapy is only about 50 to 60%, 30 to 40% is the rest of the pain specialists they refer. So in order to be a lot many onco-surgeons and oncologists, they refer to the anesthesiologist for the pain management many times.
Okay.
Kumadi madam was saying something. Madam, you can continue, please.
No, the question I think was if anybody has to start fresh, how do they go about it? Is it?
Yeah, that's also one aspect, because our youngsters would be concerned about not just the interest in the pain medicine practice, but would they get the patients? Would they be able to earn some money out of it? So is there a timeline? How long they should be waiting?
Yeah. See, the thing is like that. Our days when we were interested in pain and started with it, we did not have any fellowships in India, as Pratibha already told. But now there are a lot of 15 days courses and 3 months courses that are happening, and observation courses that are happening across India. Now the opportunities are also increasing for the budding pain physicians. And so so that was already told to you all by Dr. Pratibha. So you can even, we have started, Pratibha has started a fellowship in our institution, and we also have observation for 1 month. Okay, they can just come and observe for 1 month and learn from us. And we are also thinking of starting some 15 days, the priming course, just to create interest in the youngsters. So that is still in the pipeline. And coming to the, the opportunity for the youngsters, the pain medicine is growing like anything. And both with the procedures and starting the academic courses, people are really take from me, they are minting money. And you don't have to really depend on anybody if you are efficient. And we ourselves in our institution, we are giving good results to really make us feel good about it. Yeah, I think I've answered your doubts.
Yeah, that should be an encouragement now for the youngsters, as you say.
Dr. Bhaskar, I think in Kidwai Hospital, there is a basic course of Part A, Part B. Okay.
Yeah. That is for palliative medicine.
Palliative medicine.
Palliative. Very good. And they have started the MD in pain and palliative care. I think 1 or 2 seats are there even in Kidwai.
Yeah, it's on. Nazir, Dr. Nazir?
Nazir, a very good job, Nazir. Good job.
No, I want to add some more points here.
Yeah.
Please go ahead, sir.
Go ahead.
No, what as a pain physician I'm facing problem is when you finish your post graduation and directly jump into the pain practice, it is the most difficult task because you cannot earn bread and butter. Number one. Number two is awareness among our own colleague and other colleagues, because this is very important. How to bring it is at the doctor level and patient level. Doctor level, every medical college should have a separate pain clinic, so that then doctor should recognize, then only they can refer. Number one. Second is the awareness among the public, because what I am getting a patient is all direct patients. So maybe 10% are referred because of result oriented, but it has taken a long time. But you want to reduce the practice and earning time or clicking time, it is, you have to create awareness is the most important. That's why pain clinic should be a part of the anesthesia department in every medical college or bigger hospital. Then only people will recognize, then they know that it is a separate specialty. Without awareness is the problem here for us. Otherwise, there's a lot of work. Maybe you can say one pain specialist for 10 lakh people or 20 lakhs. All over India, maybe 1,000 pain physicians. But population is 137 million. So this is the awareness creation is there either in the syllabus, and PG should be oriented from the first year only. And anyhow, MCA has included the pain management as a specialty in this one. Then only you can click. Otherwise, you have to start the practice, anesthesia practice. You do 2 hours, 3 hours pain practice is a separate, not in the hospitals. You have a clinic, create awareness, then gradually switch over to your pain practice if you are getting sufficient this one. This is what I have seen in my practice, and that is a result of it take a longer time to establish.
Not only the awareness, even the reference from our own doctors are not going to be helpful there, especially orthopedicians are not sharing their cases there. And they avoid it, they criticize the pain physicians there. And especially in Bangalore, a group of people came from UK, started relief with 2-3 branches in Bangalore, but they utterly failed and went back there. Now only the good work is going on in Bangalore is in Kidwai to a certain extent, then site care and HCG hospital and Mahavir. Rest of the institutions, not many are doing this because there's no encouragement, awareness, and there's no references also. As Balbhaskar sir was rightly asking, how you get the references? Patient coming straightly, awareness is very less. And sharing the patients by our colleagues is very, very bad. They actually criticize pain patients now. In India now it has grown into such as AIMS, Rishikesh has started DM in pain medicine for 3 years now, from last year there. So there are not only fellowships, even the regular courses for post-doctoral courses have also started there.
Dr. Avati sir is there? I think he moderator he has. Or anything, Kodanram sir, you want to add anything? We are already past 9 past 9, 5 past 9, sorry.
It has been an enlightening experience with both the topics, and we enjoyed it thoroughly. I think we should wind up the session here. I thank all the organizers, the speakers, and my co-moderator, and all the office bearers of the Karnataka ISA for the opportunity given. And thank you very much.
Thank you, sir. Ravi sir and Najir sir, thank you very much. Balwas sir, you want to make some concluding remarks, and then Vijayanand sir, and then we'll close.
Thank you. As usual, the program has been good. And in fact, the second half, I think, is more successful because it is a focused group. In the sense, almost 100 people were definitely interested in pain medicine, and they have been there through this particular session. And I'm happy with the second announcement from Dr. Vijayanand that there is going to be a very good initiative from ISA Karnataka for basically promoting research presentations at the Karnataka state level. Otherwise, we would have lost this opportunity. So I congratulate ISA Karnataka for having taken this nice step. I think he said we are going to have them from tomorrow onwards itself. So probably once the required number and whatever papers are received, and he suggested December 2nd, Saturday, Sunday as the dates. Very happy for the decision, and I appeal to all our members to take advantage of this nice initiative by ISA Karnataka and see that this program also becomes successful, and we set an example for rest of the country. Thank you very much.
Before Vijayanand sir makes a concluding remarks, I forgot to announce the winners of the second quiz round. So for the first question, it was some mobile number DDBC5E3. I think we'll skip that. For rest of the questions, Dr. Anil Kumar MR has answered correctly and first. So I have his email ID. We'll send the certificates by email. Vijayanand sir, concluding remarks, and then we'll close.
Thank you, Dr. Nasir. Excellent presentation. Probably you got exhausted at the end, I believe. Such a wonderful thing, which is going to help a lot of youngsters who wants to be a pain physicians. And thank you, Dr. Ravi, Professor of Head of the Department Anesthesia, JJM, for accepting and conducting a wonderful topic on perioperative arrhythmia. I thank my teacher, Dr. Kodanram sir, for coming and chairing the session and moderating this session, fifth educational program of the Karnataka ISA. I thank Mahadev Avati. Probably he was traveling, I believe. He was busy also. Thank you, sir, Avati sir, for being a chairperson. And I thank all the seniors and all the teachers for participating. Thank Dr. Balbhaskar and Dr. Gurudat for taking the pain from last 1 month. Every month they are taking reviewing the slides and bringing this program as a very prestigious and very good academic program, which they are toiling very hard. Thank you, sir, once again. I thank Dr. Kameswar Rao, Dr. President-elect Dr. Venkatagiri, sir. And he is very much interested in his program, which is going to be held in the 1st of November, which he missed the date there. It is one more opportunity. I thank all the participants, all the senior teachers who contributed to this lecture. And lastly, I request all the postgraduate private practitioners to participate in the virtual conference, which will be held on 12th and 13th of December. And it will be a very great feast. You can present, in spite of your busy schedule due to the COVID duties, you can do everything. We have done a lot of homework on this to accept it as even till the last date, accommodate as much as papers, and there are a lot of awards. You can really take this. This would be helpful for your career as well after your post-graduation. I thank everybody for participating. I thank Sri Ganesh, who is relentlessly doing a wonderful job. And we are going to celebrate our World Anesthesia Day, which will be announced shortly. Please, wherever you are, all the city chapters, people, please participate and be in touch with Sri Ganesh. You can share your programs, which will be webcasted. We will announce the detailed program with you in consultation. If you are having any programs, if you want to participate in World Anesthesia Day, please contact Sri Ganesh also. Thank you. Thank you very much.
Thank you, sir. Please note that our presentations are available on our website, isakarnataka.org, including both the sessions that we had today will be available. And I thank both the speakers again, both the moderators, Kodanram sir and Avati sir, speakers Ravi sir and Nazir sir for their time and excellent presentation. Thank all the national, regional and state officials who participated, the postgraduates, their teachers and practitioners as well. And I must especially thank Balvaskar sir and Gurudat sir. They are our academic coordinators for ISA Karnataka. Balvaskar sir, despite his health issues, he was able to guide us. And Gurudat sir, as always, works behind the scene, but very effective. And the next month's program is already highlighted. We have 2 excellent presentations again on the second Thursday. Yeah, you can. It is on your screen. One from Belgaum City branch, and the topics and everything is shared. And I'll share it again as we go ahead. Before we conclude, I thank also A1 Logics for their continued support for our online education program. Shilpa, you are there?
Yes, sir.
Yeah, thank you very much.
Thank you, sir.
Thank you, everyone. It's quite a long time we have had this session. Thank you again. Good night.
Good night. Thank you.
Thank you.
Thank you. Thank you all.